各位贵宾，我们的大会主讲场次呢，马上正式开始哦。要请各位贵宾再稍后一下，那也提醒各位贵宾记得将手机转为震动或静音。那今天呢，配合防疫的关系，要请各位贵宾全程佩戴口罩。谢谢 ，Ladies and gentlemen. We're going to begin in just 1 minute. Please take your seats. Kindly turn your mobile phones into vibration or silence mode, and please have your mask on at all times. Thank you. Ladies and gentlemen, good morning or good afternoon and good evening to all the friends who join us online. Welcome to the second day of 2021 Global Health and Welfare Forum in Taiwan. 非常欢迎所有现场以及线上的贵宾好朋友们继续参加我们第2天的2021年台湾全球健康福祉论坛哦。We're now in plenary session 2, and we're going to explore the impacts and consequences of the pandemic to the society. 那我们今天一开始的大会主讲场次2呢，会聚焦在疫情长期对于社会的影响。And now, please welcome your moderator of this session. Please welcome Professor Geng Yiliang, President of National Health Research Institute Taiwan. 让我们首先有请我们场次的主持人，国家卫生研究院梁耕耘院长为我们开场，我们掌声欢迎院长。
Thank you very much. I think things is onset. The COVID-19 really affects our daily life tremendously, just about everyone in the world. So I think it's time to examine the impact and the consequence of the pandemic to the society, and to see how we can cope with and move on here. And we have 4 excellent speakers, and without further ado, let me just introduce the first one. It's Professor Michael Lu, who's the Dean of School of Public Health at UC Berkeley. And the title of his talk is Voice from Public Health. Professor Lu, please.
Yes, do we have Professor Lu online right now?
Can you hear us, Professor Lu? You probably need to be mute.
Yeah, Professor Lu, we cannot hear you.
I'm unmuted.
Yes.
Okay, we hear you now.
Can you hear me okay?
Yes, please.
Okay. 大家好，然后贾大伟，我叫吕纯琪。
Ladies and gentlemen, good morning. My name is Michael Lu Chunqi.
It's such an honor to be invited back to speak at this forum. And let me just start by saying that I am just so proud to be a Taiwanese American right now, that despite outbreaks this summer, that Taiwan remains one of the few shining examples in the world of what a strong public health system and leadership can do to protect the health and safety of its people. In contrast, COVID-19 has been an epic failure for public health in the United States. Now, this in no way takes away from the heroic efforts of so many of my colleagues and friends all around the country, without whom the human and economic toll would have been much worse by orders of magnitude. But the numbers speak for themselves. With more than 46 million cases, 750,000 deaths, and trillions in economic loss, at a moment when America needed public health most, our public health system failed to protect the health and safety of the American people. So what went wrong? I thought I would share 8 lessons learned from COVID and what the US and the world must do differently to prevent and prepare for the next pandemic. So first, the COVID has shown us the price we pay for chronic underinvestment in public health. The United States spent more than $3.8 trillion in healthcare last year and less than $100 billion in public health. For every dollar spent on healthcare, we spend less than 3 cents in public health. Given that healthcare accounts for only about 10 to 20% of what contributes to people's health, continued overfeeding of a broken healthcare system while starving public health will do little to improve the nation's health. Second, COVID shows how much public health depends on public trust. When you had a president and his follower spread misinformation, disinformation, sideline federal agencies and scientists, and politicize lockdown, masking, testing, and even vaccines, and we see how that continues to play out in many states where governors threaten to withhold funding to school districts that require students to wear masks inside the classroom, you're going to create a lot of mistrust and distrust about public health. Third, COVID shows just how decimated our governmental public health workforce has become. Over the last decade, state and local health departments have lost more than 50,000 staff from federal, state, and local budget cuts. The governmental public health workforce is down to less than 200,000, and another 50% is thinking about leaving or retiring.
Michael, we're sorry to interrupt because it doesn't go full screen, so you probably have to let our staff here have access to turn your PowerPoint into full screen. Or, yeah.
I'm sorry. How should I do that?
还是我们教授可以自己开 ？Yeah, you have to go.
你们看得到吗？
你这边可能要开全荧幕，是要他开全荧幕还是他开全线？开全。Yeah, you just go full screen. Down there.
Okay.
Yeah. Yes, great.
No.
Okay, back to you.
Is that better?
Yes.
Okay, sorry about that.
Yeah.
All right, so as I was saying, this compares to a physician workforce of over 1 million doctors in the United States, which is why many health departments found themselves in the middle of this public health crisis, unable to maintain core functions, let alone fighting the pandemic. Fourth, COVID put our nation's antiquated public health data infrastructure to the test, and it failed disastrously. It's crazy to think that at a time when big data and supercomputing, AI and machine learning is changing industries from manufacturing to commerce, from defense to healthcare, most health departments are still relying on paper and pens, desktops, and fax machines. Most of the machines don't talk with each other, and they don't link to EHR. They don't track social determinants. It's little wonder that we have such a hard time predicting and preventing outbreaks, tracking disparities, forecasting hospital bed capacity, and managing vaccine distribution. Fifth, COVID exposed just how unprepared we are as a nation for a major public health crisis. Countries that were successful in containing the virus, like Taiwan, Singapore, Korea, and New Zealand, all have robust public health systems that took early action, set up unified command, executed a coordinated and science-based national strategy, deployed massive technological and human resources, ramped up testing and contact tracing, and communicated transparent and trustworthy information to the public. We did none of that. Our federal government was unprepared, misguided, and disorganized. What complicated matter is that our federalist public health system in the United States, we don't have one public health system. We have 50 states and 2,634 local public health systems, which would have been all right if we had strong coordination across federal, state, and local public health departments, but we didn't. In the absence of that, states had to fend for themselves and had to compete with each other for PPEs and other supplies. Now, imagine if the US military responds to a foreign military invasion the way US public health system responded to COVID, letting states and local militias defend for themselves. The United States would be in big trouble. 6, COVID-19 has shown us just how interconnected our world has become. An outbreak anywhere can quickly become a global health threat everywhere. And America's national interests are inextricably tied to global health threats. As I said, for decades, many countries looked to the United States for assistance in combating health threats. The abdication of the US global health leadership by the Trump administration in the face of growing global health threats was irresponsible and dangerous. But it's not just the fault of the United States. COVID-19 exposed just how weak the World Health Organization has become. Without real authority and real resources to enforce international health regulations, whether it's assuring that member states report an outbreak without delay or deception, or assuring equitable distribution of vaccine to half of the world population that still needs to get vaccinated, COVID-19 has shown that the WHO is all bark but no bites. 7th, COVID-19 offers one more example of how the US tends to do too little too late when it comes to prevention. Chronic diseases is another example. We've got 70 million Americans who are turning 65 and older in the coming decade. 2/3 of them are going to have 2 or more chronic diseases for which our current healthcare system isn't equipped to deal with. If we don't figure out how to better prevent and manage chronic diseases, we're going to bankrupt our next generation. So how much are we spending in chronic disease prevention? Well, last year, the CDC spent $3 per capita on chronic disease prevention, while the country spent over $10,000 per capita on the treatment of chronic diseases. And 8th, COVID-19 laid bare the magnitude of health inequities in the United States. Now, while differential access to testing and treatment might have played a role, much of the COVID-related inequities have been driven by social conditions such as crowded housing, occupational exposures, economic insecurity, and structural racism. Without improving the social conditions in which people grow, live, work, connect, and age over the life course, improving healthcare improving healthcare access alone will do little to improve population health or advancing health equity. So what must the US and the world do differently? Since I was asked to be the voice from public health at this forum, so first and foremost, I would call on US government and governments everywhere to invest in public health. So if the US is spending 3 cents on public health for every dollar that we spend in healthcare, let's spend 6 cents, let's double that. We can finance it through averted costs or increase taxation on medical services. Second is to restore public trust. If there's one lesson that we learned from COVID-19, public health officials everywhere must learn to communicate clearly and effectively to the public. Their guidance must be based on the best available science and evidence, and we must all get a lot better in combating misinformation and disinformation, especially on social media. In the United States, there's now a cultural war against science, against public health, and we're going to lose if we don't get a lot smarter in how we fight. Lastly, we need to protect the scientific integrity and the independence of public health agencies and scientists, as we learn from COVID-19, the stakes are too high to hold the public's health hostage to political gamesmanship. Third is to revitalize the public health workforce. Many of us in the United States have called for the government to increase the public health workforce by 100,000 in the next 5 years. And I was glad to see that in the American Rescue Plan Act, $9 billion to strengthen public health workforce, which is a good start. But we can't just be adding people to do the same old. The definition of insanity is to do the same over and over again and expecting different results. We need to be training a whole different kind of public health professionals. COVID has shown us that big changes are needed in public health and in the world. And we need more public health change makers who know how to bring about real change. And that's why here at Berkeley, we're transforming our curriculum and pedagogy, greater emphasis on what we call change-making competencies, such as leadership, management, communication, collaboration, strategic thinking, community organizing, policy, and advocacy, to make sure that we're equipping our graduates not only with a world-class education in the 5 core public health sciences, but the knowledge, the tools, the skills they need to go out and change the world. Fourth is to modernize public health data infrastructure. We need to build a public health data superhighway for the 21st century with an enterprise-wide core data exchange infrastructure, which allows the CDC, the state and local health departments to move from siloed, sluggish, manual, paper-based data collection to seamless, automated, interoperable, and secure data systems that yield critical information in real time. It would also allow for better data integration with electronic health records and other data sources, especially those monitoring social determinants of health. Fifth is to strengthen our national health security with a national health security coordinator at the White House to coordinate federal, state, and local response, a national health security budget with no year funding, at least $2 billion in the reserve, and a system-wide upgrade of federal, state, and local capacity for emergency preparedness and response. Six is to strengthen global health security. The United States must step up, starting with assuring equitable vaccine distribution around the world. This is a race now between how fast the virus can mutate and how quickly we can get the rest of the world vaccinated. And the United Nations must step up in enacting and enforcing a new international agreement on pandemic prevention and preparedness and providing centralized command and coordination in response to global health security threats. Seventh is to prioritize prevention. In public health, we talk about primary, secondary, and tertiary prevention. Primary prevention is preventing spillovers from happening in the first place, which will require protecting wildlife from the relentless human encroachment on their habitats and enforcing international laws to stop illegal wildlife trades in which the US and China are the major culprits responsible for 60% of these trades worldwide. Secondary prevention is about early detection and response. Just like we have early warning systems for tsunamis and the earthquakes, we need to build a global early warning system for pandemic preparedness through a combination of zoonotic reconnaissance, AI surveillance, and outbreak investigations. Tertiary prevention is to mitigate pain and suffering once the pandemic has occurred. And sure, we need to invest in new technologies, new platforms for rapid vaccine development and novel drug discovery. But let's also make sure that we're investing in building a robust US and global public health infrastructure, which the world desperately needs before the next pandemic strikes. Lastly, is to advance health equity, recognizing that health has less to do with healthcare than it does with the air we breathe, the water we drink, the food we eat, and the physical and social conditions in which we grow, work, connect, and age. Advancing health equity will require all of us to fight for environmental justice, for affordable housing and fair wages, for health as a right and healthcare for all. It requires us to fight against all forms of social injustice. We're not going to achieve health equity in the US and around the world without fighting social injustice and dismantling all forms of social and economic oppression. Public health can lead the way, but first it has to become a lot more anti-racist in the United States and a lot more anti-oppressive around the globe. The novelist Arundhati Roy reminds us that historically, pandemics has forced humans to break from the past and imagine their world new. This one's no different. It's a portal, a gateway between the one world and the next. COVID-19 has forced us to rethink and reimagine public health. We've got big problems in the world. We've got big existential threats, from climate change to pandemic outbreaks, from chronic diseases to social inequality, which require public health to be front and center in driving solutions. But instead of rushing back to normality, instead of trying to get back to normal, we in public health need to be bolder, more imaginative, and more transformative. Let's learn from the lessons of COVID-19. Let's roll up our sleeves. Let's imagine a new world, and let's get ready to fight for it. 谢谢大家。
Thank you very much, Professor Lu. And for the interest of time, I think we'll move on to the next speech. And I hope that all the four speakers can stay until the end, where we'll have a panel discussion, entertaining the questions from the audience. Our next speaker is Dr. Ryan McFarland, who is the director from the Crowell and Mooring International. And he was speaking to us about the healthcare financing, APAC healthcare financing roadmap. Dr. McFarland, please. You need to be unmuted. Yeah. Hi. Can you hear us?
Yes. Let's see. Hold on.
Okay, it's good. Thank you.
Can you hear me okay now?
Yes, please.
Excellent. Thank you very much. It gives me great pleasure to join you all for this great forum. I wish I could be there in person. Hopefully next time this year, we'll all get to be together in the same room. But what I did want to do is just briefly go over some of the impacts from the COVID-19 pandemic, and then highlight some of the issues that have actually even taken place just today in the G20, and then give a little bit of an explanation of how we are trying to address at least part of the healthcare financing issue within APEC, the Asia Pacific Economic Forum. So very briefly, I don't really have to go into much detail on this. I think everyone is well aware of the extreme impacts that COVID-19 has had to our society, both on a morbidity and mortality impacts, but also within the broader economic impacts. Estimates are that there will be over 22 trillion lost in economic output between 2020 and 2025, which is an absolute incredible amount of economic loss, really the largest shock to the economic system since World War II, and the largest synchronous impact to the global economy since the Great Depression of 1929 to 1930. And really, no other time in history has health and our economic security been so dependent on global cooperation, and has there been such a need for increased investments in our healthcare systems. So in the interest of time, I'm not going to go over all of the impacts here. I think everyone is well aware of this. There's just some of the impacts that were elucidated in a recent study by UNESCAP that looks specifically at Asia Pacific and the achievement of the Sustainable Development Goals, and the progress report that was published in 2021. But just to indicate that not only is this an economic issue, but also issues around mental health, around informal workers, around labor income being lost, around child morbidity. There's just huge impacts to the COVID-19 pandemic, and I think we'll be learning more and more about these impacts as the years go on. What I did want to do just briefly is just go over some of the kind of recommendations that have been made regarding pandemic financing. And I think this forum is extremely timely. Just for those in the Western Hemisphere, just today, G20 leaders met, and on Friday and Saturday, health and finance ministers from G20 economies actually met to discuss pandemic financing. Some of the issues that were raised in a report that was presented to G20 health and finance ministers included recommendations on the need to invest substantially more than we have been willing to spend in the past, that countries need to step up their domestic investments, that governments need to make reforms to mobilize and sustain additional domestic resources, that low and middle income countries will need to spend about approximately 1% of GDP more on public spending on health over the next 5 years, that will need to ensure reliable funding to enable public-private partnerships. And importantly, that this scale of financing is going to require sustained and increased resources from every source. So that's public, private, and philanthropic sources are going to be required to meet the need. They also recommended that there's going to be a need for a different construct of partnerships. So in addition to kind of the policy changes that'll need to be made, there also began differences in the way we kind of do business in terms of engaging with external stakeholders. There's going to be needs for significant increases in private sector investments, including in the broader development financing and particularly for infrastructure. The report also noted that there's a significant scope for expanding the use of risk mitigation tools and also to include more use of blended financing instruments. So essentially what we want to do is to use governments and multilateral development banks to actually crowd in additional private sector financing. There's quite a bit of money that's actually available to invest and is actually looking for places to invest. And so the issue is just de-risking some of that investment and providing an environment where we can actually crowd in or incentivize additional private sector investment, because it's really going to take investments from, as I said, private sector, philanthropic, and governments to really meet the need that we have right now. And so that is really a lot of the work that we've been doing in APEC, is looking at ways of how can we actually, one, present health in a way that is actually important and kind of we speak the language of finance ministers. How can we show finance ministers that by investing in their healthcare systems that they actually can receive a return on that investment? And what are some of the investments that they should be making? In the interest of time, I'm not going to go over all of this calendar right here, but I did just want to highlight a few things that we have been doing in APEC, specifically on health financings. I think it will be very relevant for how we look at pandemic preparedness and response financing in the future. So in terms of the initial work that we did within APEC, a lot of it was really focused on how do we convince finance ministers that investments in the healthcare system will actually result in an improvement in economic growth. And so how can we, by investing in our healthcare systems, reduce some of the losses from productivity due to increases in non-communicable diseases and aging populations. And so we collaborated with the APEC Business Advisory Council, the Victoria University, on a study that showed that APEC economies are actually facing a fairly significant GDP loss between 6 and 8.5% by 2030 due to the projected steep rise in non-communicable diseases. We also had APEC ministers and leaders recognize the issue in the various statements that come out every year. And in particular, I wanted to note the statement from the 2017 Finance Minister's Statement, which encouraged additional dialogue between APEC member economies, and in particular to explore best practices and to look at innovative and sustainable healthcare financing solutions. And so that is a lot of the work that we've been doing within APEC, is how do we create a policy environment where we can actually increase private sector engagement, increase private sector investment? Because I think based on what we've seen from the recommendations from the G20, based on the needs that we know that we have in terms of achieving the Sustainable Development Goals, based on the needs that we know that we have in terms of financing our healthcare systems, we are going to need significant more investment. And so what can we do to kind of increase private sector investment and use those funds that we do have as efficiently as possible? And so within APEC, we created a checklist for policymakers to evaluate their own policy environment. And so this included various indicators on the political will and government coordination. So is health a priority within this government? We looked at good governance issues. Are the funds that are being allocated to healthcare systems being used as efficiently as possible? We looked at private sector engagement. Are there ways for the private sector to engage and actually kind of pump in that additional needed capital to the healthcare system? We looked at the legal and regulatory frameworks. This often can have implications for developing new insurance products, but then also clarity in terms of legal and regulatory frameworks can help de-risk some of the investments on the private sector side. We looked at health and financial literacy. So is health and things like insurance valued and appreciated within the economy? And then also we looked at quality data and evidence, because having quality data and the ability to access that data is often critical for a number of these alternative financing mechanisms. So when we look at different healthcare financing mechanisms, what are we talking about? These could be fiscal measures like excise taxes on various transactions. They could be financing arrangements, grants, bonds, as I said, blended financing arrangements, or they could be insurance arrangements ranging from your typical insurance products to health savings accounts and more novel insurance products. Within APEC, we also developed some specific bilateral engagements. Again, in the interest of time, I'm not going to go into all of the details on this, but we have done a series of engagements with various APEC economies looking at that particular healthcare system and looking at ways that they can, one, increase investment, particularly in healthcare infrastructure, increase private sector engagement, but then also make sure that they're using those funds that they do have as efficiently as possible. And so we came out first identifying some of the barriers and then also looking at some of the recommendations for specific APEC economies. And then again, a similar dialogue was held in Japan. This was during 2019, actually, when Japan was hosting the G20 and actually convened health and finance ministers for the first time. And again, in the interest of time, I'm not going to go into all of the details on this, but just to say that there are recommendations and things that APEC economies can be doing to incentivize the development of these new and alternative financing mechanisms. In the past year and a half, we have switched to kind of a virtual engagement. A lot of the work that we have been doing has been looking at specific healthcare financing mechanisms. And so whether those be looking at how to encourage private sector investment, looking at blended financing arrangements, looking at the issuance of social impact bonds or health impact bonds, encouraging or developing new private insurance, looking at digital, fintech, and insurtech solutions. A lot of these solutions are enabling patients and customers to essentially lead healthier lives and actually follow their treatment regimens better through the use of digital technologies. And then also looking at the role of impact investors from various philanthropic and multilateral development banks. We've been very fortunate to collaborate with a number of different governments and development agencies, in particular USAID, the U.S. Agency for International Development. They have developed a number of different studies looking at these various issues, including how to encourage private sector engagement, how to mobilize additional private sector capital to reach global health goals, various blended financing arrangements and how those can be used to achieve global health goals. And then, as I mentioned before, the use of social impact or health impact bonds and how those can be used to achieve health objectives. We've also partnered with the Health Financing Institute. They have developed a number of different tools to help interested APEC economies utilize things like blended financing arrangements, and kind of goes over some of the necessary policies that will allow for these blended financing arrangements to really take hold, and how to crowd in that additional capital, whether it be from philanthropic organizations, private sector organizations, or others. Again, in the interest of time, I will skip over a lot of the details on this, but just to say that there also are a number of different factors that can be used to help encourage the use of health impact bonds. And then we've also done a series of webinars, including those looking at private health insurance. And so how do we kind of develop new collaborations between insurance, healthcare providers, foundations, governments, and others, and how can we use digital technologies to improve patient outcomes, and then also result in cost savings, both on the private sector side and the government side. As I mentioned, we've also looked at some digital fintech and insurtech solutions. And so these can be things like digital lending, insurtech, including disease-specific insurance, looking at how AI and other advanced data analytics can be used to help patients lead healthier lives. And then we also looked at a series of case studies, including MTBA, which is a mobile health savings account. This allows people to actually save money for specifically for health. And then also another case study, Aroya Finance, which provided low interest loans for medical care, and also provided for alternative risk scoring. A lot of times in a lot of developing economies, many consumers will not have kind of the typical data that would allow them to take out loans or to be included in the traditional financial system. And so this was a mechanism to use kind of alternative risk scoring metrics to allow them to be included in that financial system and receive and have access to advanced financial products. We've also, again, we're very fortunate to partner with USAID and others on a series of studies that looked at a lot of these different tools. We've also looked at the role of impact investors, and so this can be foundations and what they are kind of looking for, how they can be used to provide either catalytic capital or patient capital to de-risk investments. And also heard from the financial services sector and some of the things that they are doing to kind of scale these new innovative financial mechanisms. All of this material has been kind of collected and put on the APEC website. And so we've had nearly 500 participants in our webinar series so far. And all of the reports, presentations, and webinars are all included on the APEC website, which can be accessed at www.apec.org/healthcare financing. And finally, we've developed a healthcare financing roadmap, which is a forward-looking plan that's really looking at the additional tools, studies, and activities, and also we'll be looking at how do we engage with specific APEC economies that are interested in developing these new financing tools. How can we work with them to actually implement these new tools? And finally, my last slide here, I just want to highlight a policy dialogue that we'll be holding through APEC, and this will be with health officials, with finance officials. It will be conducted through the Life Sciences Innovation Forum and the Health Working Group, and it will look at this new roadmap that has been developed, and we'll look at what are some of the issues that specific APEC member economies are interested in pursuing. And so I invite everyone that would be interested in attending to please get in touch. We'd be happy to have all of the participants from Taiwan attend this meeting and look at how we can actually start developing and utilizing these alternative financing mechanisms. I think there's a lot that has been learned from the pandemic financing experience, and I think this can be applied to non-communicable diseases and other disease states. And with that, I'll turn it back to our moderator. Thank you very much.
Thank you very much, Dr. McFarland. And I guess I'll ask the audience to hold your question until the end of until the panel discussion. Our next speaker is Professor Zhirou Chen, who is the director of the Institute of Sociology, Academia Sinica. And the title of his talk is The Social Impacts of COVID-19 Pandemics in Taiwan. Director Chen.
Okay, thank you, Professor Liang. And it's my honor and my pleasure to be here, especially as a sociologist, a local sociologist. But I just realized we, like the public health experts, examined very similar issues. So today I'm going to present the social impacts of COVID-19 pandemic in Taiwan. And unlike the other panelists, my paper, my report is focused on Taiwan, and as you will see, is based on a pilot study and with a very simple result. Okay. And the background and question of my report, we know Taiwan have suffered relatively modest losses in terms of lives, human lives, and the impact of the economy. And compared with the other countries during the global pandemic. And it was not until May to July this year that Taiwan experienced a severe outbreak. And we know for several weeks, the closures of the service industries and public institutions have made the public very upset, very angry about the government. And the slowing of the economy during those several weeks had caused harms, damages to certain people, to some social groups. And this is the topic of my report, and we know these harms, like other countries, have emerged differently for different social groups, for different disadvantaged groups, and have long-term impacts, even in Taiwan, which suffered modest losses of human lives and the impact of the economy. So the question for my report basically is, in Taiwan, who suffered, and in what respect, and to what degree? And I will use a data phone survey conducted by Academia Sinica. And this is kind of the annual survey we have been doing in Academia Sinica. And for this year's survey, we focused on the impact of the pandemic. And it has a representative sample of 1,200 respondents. And it's from a household phone survey. And actually, I just completed the questionnaire designs for our second wave surveys to be done in November by phone and by internet. So I will report to you the results of this survey. And for example, in general, Taiwanese people are kind of happy about what the government is doing. 64% of Taiwanese thought the Taiwanese government is doing a good job. Not so good, right? Even Taiwan has been quite good in terms of global pandemic treatment, okay? And 42% of Taiwanese people thought US government is doing a good job. And 29% of Taiwanese thought PRC government is doing a good job in handling the COVID-19 outbreak. Even China seems to be better, to do better than the US, right? And we can see the vaccine acceptance in Taiwan is quite high. Taiwanese is more obedient and afraid of death, right? 台湾人贪生怕死. So you can see the survey was done in August. So in August, 30% of people reported they have been vaccinated. And 64% of them reported they will. They definitely will and or most likely will to have vaccination. Only 5% of them reported they will not get vaccinated. Okay, so for the vaccine acceptance in Taiwan is quite high compared to other countries. And we can see the relation between personal income, the change of personal income. So in August, 54% of the respondents report they have seen their personal income the same or a little bit more. 42% of them reported they suffered from less income in August compared with their income in March and April. And this is in terms of household income. And a little bit higher, 53% of them reported they have less income in August compared with March and April. So it's fair to say that half of the household suffered financially in Taiwan due to the pandemic for this year. This is from people's subjective feeling. Okay. And who are they? What are the occupational groups which suffered financially from the pandemic? And we can see, for example, most of them are in the self-employed sector and employers with employees. For the people in government sector, 12% of them reported they have their income decreased. But for those who work as self-employed without hiring people, 74% of them reported decrease of personal income. And for those who hired people, 69% of them reported decrease in personal income. So we can understand for street vendors, for informal sector workers, for the owners of restaurants or shops, they do suffer financially from the pandemic. And then we look at the generations, the age groups. And the older generation who are 50 years old and above, 45% of them reported decrease in personal income. But for the younger generation, only 34% of them reported decrease in personal income. So there is a difference in terms of age groups. And most people receive government relief benefits of the relief package 纾困 4.0. Okay, 52% of them reported no, but 46% of Taiwanese reported they receive government relief benefits. And we can look at the social trust in Taiwan, and social cohesion is an important issue in terms of the impacts of the pandemic. So in general, Taiwanese people think the public can be trusted. 61% of them reported they thought the general public can be trusted. And then we look at the pandemic, whether the pandemic affects people's social trust. And for those who have low social trust, who have less trust to people, for them, 53 of them suffered the income decreased. Okay, so it means for those who suffered income decrease, they are more likely to have less social trust. This is an effect of the pandemic. And then we look at the issue of social isolation. We used a loneliness index, and we combine a loneliness score from the following questions. We ask the respondents, when in trouble, do you have many people to lean on? Or do you have many people to trust? Do you often feel empty? 感到空虚啊。Do you want company? Do you think there are many people you feel close to? And we combine these questions, the replies of these questions, to construct a loneliness index. And then we can see the pandemic indeed affects people's social support, indeed affects people's feelings of loneliness. For those who have seen their personal income decreased, they have much higher loneliness scores, which means they are more likely to report symptoms of loneliness. And so this is very clear that pandemic indeed affects people's social support, social isolation feelings. So the final remark of my report is, as vaccination rates increase in Taiwan, Taiwan will likely be able to contain most of the life-threatening effects of the pandemic. So for the public health, for the physical health, it could be contained in Taiwan. But Taiwan, like many other countries, we have seen the social impacts of the pandemic on specific vulnerable groups are worsening existing trends. The social inequality is widening. So these questions, these impacts preceded and will outlast the pandemic. It will continue after the pandemic. And they provide a useful starting point for further engagement and understanding of how we will work together to address them in policies and benefit provisions. Thank you.
Thank you, Director Chen. Our last but definitely not least speaker is Dr. Susan Frantong. She's the president of Plantry International. And the title of her talk is Inclusive Stakeholder Partnership, How the Pandemic Exposed the Fragility of Person-Centered Care and what we need to do now to course correct. And Dr. Frantong is on her way on the road, and she won't be able to present her talk in person, but she does have the pre-recorded tape, so we're going to play the tape.
Thank you so much for inviting me to participate in this program that's exploring the needs of various stakeholders in the healthcare enterprise. I'm Susan Frampton, the president of Plantry International, and our organization works with healthcare sites around the globe, working with them in particular on implementing patient and person-centered care approaches to the delivery of care. And as I think we've all experienced, the COVID-19 pandemic has had significant impacts on many aspects of the patient and family experience of care over the past 18 to 20 months. The restrictions that have been put into place, particularly on the presence of family members in clinical settings, has resulted in many unintended consequences to all involved, patients, families, nurses, and other caregivers. While some of these restrictions have been lifted, some still remain. And it's important that we explore strategies both for this current situation and perhaps the next public health crisis around effective advocacy for evidence-based, person-centered approaches to family involvement policies. I'm going to share with you today some practical ways to apply family presence guidelines that keep everyone safe, patients, families, and staff, but also keep people together when they most need to be together, which is often in the healthcare setting, during challenging times. Why is this so important that we keep patients and families together, especially during clinical encounters and hospital stays? Well, if we look at the research evidence, it's replete with studies that have shown the benefits of family involvement in the care of hospitalized loved ones and ones in nursing homes, including significant reductions in readmission to hospital, up to 25%, when family caregivers have been actively involved in discharge planning efforts. We've also seen that higher levels of social and emotional support from families result in better self-management and better health outcomes for patients, especially those with chronic illness. Other studies have shown that in the outpatient area, when patients are accompanied by a family member to their outpatient appointments, they have better information recall, are more satisfied with their medical encounter, and obviously with better information recall, we would anticipate better and more appropriate compliance with the treatment regimen. And then lastly, in the hospitalization of older adults, when families are involved, we see a reduction in things like delirium, which unfortunately is often a byproduct of hospitalization of the elderly. So there's a lot of good reason for us to be concerned about any policies that would limit the involvement of the patient's family during their care experience. And yet during the COVID-19 epidemic, we saw many restrictions put into place out of a concern for safety. During the pandemic, families were separated from loved ones in hospitals and in nursing homes, and we saw devastating reports in the media from around the world of hospitalized patients dying alone with no family present, or family being relegated to the sidewalks outside of the healthcare facility, perhaps watching their loved one pass away on a tablet, unable to be at their bedside. We saw reports of elders locked down in nursing home facilities with no family visitors for months at a time, who became more and more isolated, depressed, fearful. We experienced increasing rates in those elders of delusional thinking, of dementia, and for some, death resulted from these family separation policies. So while our intention was to keep everyone safe, for some, the result was just the opposite. We at Plaintree reached out to many of the healthcare sites that we work with around the world. And in particular, we reached out to sites in this survey, 33 different clinical sites in 9 countries. All of these sites are leaders, considered leaders in person-centered care and patient-centered care. They are all gold certified in excellence in person-centered care. And we asked them to what extent they had been able during the pandemic to maintain a collaborative approach to policies and practices that affected patients and families. To what extent were they able to include the voices of patients and families, which is really the foundation of the approach to person-centered care. And what we found is that even in these environments, in these leaders in person-centeredness around the world, it was a minority of these sites that were able to say that they had kept a highly collaborative process in place when they were reviewing family involvement and family visitation policies. And even fewer were able to include the voices directly of patients and families. Based on this, and some additional reports that we began to see in the literature, we became more and more concerned about these unintended consequences. And in fact, in 2020, there were a number of reports in the literature that documented how this struggle to include patients' families were contributing to everything from an acceleration of physical and mental health decline based on this social isolation. Another report, and this was in the Harvard Medical School Review, found that allowing limited family and caregiver visitation would be an important step to reducing isolation and to manage delirium in patients. However, the personal protective gear was also found to be an issue with interpersonal interactions, and was found to likely contribute to further impairment and disorientation for patients. Their conclusion was that even while we got very creative with some of the virtual means of connecting patients and families, say through a tablet or FaceTime or WhatsApp or other virtual means, that virtual visitation should only be a temporary substitute for in-person presence between families and patients. And then in a third study in the American Journal of Respiratory and Critical Care Medicine, also reported in 2020, they found that restricted visitation may inadvertently exacerbate pre-existing disparities of care. So populations that already have challenges around access to healthcare, that those challenges were made even worse. So as an organization that focuses on advocacy for patients and families, we felt that it was very important that we use some of our advocacy tools to bring together an international coalition of global leaders in person-centered care to attempt to address some of these unintended consequences. We were able to get input from the World Health Organization, from the International Society for Quality in Healthcare, from the American Hospital Association, and many, many other organizations around the world to develop a set of guidelines to preserve family presence that focused on the evidence base and what we knew at the time in order to keep people both safe, but deliver compassionate, patient-centered care. Those guidelines for preserving family presence in challenging times are available for download, and I would encourage anyone who's interested to go to this address and download those guidelines. That was a first response. We did see some impact from those guidelines as we pushed those out across many different social media platforms. In fact, we saw some states in the United States actually make changes to their regulations around family visitation. For example, the state of Indiana declared that every individual in a nursing care facility had the right to at least one essential family caregiver to be present with them at the bedside or in their room. This was real progress, but more needed to be done. In addition, we reached out to over 3,000 nurses in a survey to see what their experience of providing care during the pandemic, when these different restrictions were in place, what that impact was on them. in that survey, 90% of the nurses reported that during the past year, during the pandemic, that their organization had restricted family presence policies, and that they had felt that it conflicted with what they thought was in the best interest of their patients. Nearly 80% of the nurses agreed that with the right measures in place, for instance, social distancing, hand washing, mask wearing, that in-person family presence can be supported during a pandemic. 80% of those nurses also agreed that supporting patients with little or no access to their families had created even more of a burden on them, and that the restrictions to family presence during COVID-19 had truly negatively impacted their well-being as healthcare professionals. And so we began to see these negative unintended consequences to patients, to their families, and to our caregivers. And so we felt we needed to take yet another step to advocate for a more evidence-based approach. And so we pulled together another coalition with the support of the American Nurses Foundation to focus specifically on nurses and nursing leaders to develop resources and supports for them as they attempted to apply a more evidence-based approach to the decision-making that happened around family visitation practices. We put together a coalition for family presence in which nursing leaders from many different organizations around the country joined in and helped to develop a priority matrix of what were some of the most important things that we could do as a part of this advocacy coalition in a short period of time to address the unintended consequences that we were seeing. And so we developed a toolkit which included a framework for a more balanced, informed approach to decision making. It included a discussion guide that would help organizations to have an open and collaborative dialogue around family presence, bringing in a broad stakeholder group, not just the experts in infection control, but also nurses, doctors, patients, their families, and community members. The framework also summarized the evidence base about family presence. It included a decision aid that could help these collaborative, broad stakeholder groups assess the risks and the benefits of in-person presence of family based on 4 different impact areas. And then it concludes with targeted recommendations that are aligned with current evidence at that time. In addition, the toolkit includes a decision-making framework for the use of the decision aid, including these steps involving a multi-stakeholder group, using the data that that group collects, applying it within the decision-making matrix aid, and then assessing and discussing the outcomes of that, and to use that to shape policies going forward. This also included taking into account 4 primary aspects that are very important when we're evaluating changes to policies around family presence during a public health crisis, whether it be the COVID-19 crisis or whatever the next public health crisis might be. And that includes looking at the evidence base, looking at local conditions at the time, looking at the availability of resources, for instance, access to protective gear, and then looking at issues of equity. We then piloted this toolkit in over 20 hospitals around the country, large hospitals, small hospitals in urban and rural areas, and we had very good results. Nursing leaders reacted very positively as they used the decision-making framework to take a more inclusive and appropriate approach to decisions that could support both safety and compassion.
Okay, I believe we have the last slide with Susan's email on. Can we show the slide? 我们是不是最后一页有这个 Susan 的 email? Because Susan could not join us for the panel discussion, for she has another meeting to attend at this time. So we'll show her email. So feel free to contact her via email if you have any questions. 那大家都可以寄 email 到这个理事长的信箱哦。那接下来呢是我们综合讨论的时间。For the panel discussion, Professor Liang and Professor Chen, would you please take a seat on the stage? Yes, please. And joining us online, we will also have Professor Liu, Michael, and also Dr. McFarland, Ryan. 那接下来呢，我们综合讨论的时间哦，有请我们的院长以及所长到台上来就座。那同时线上加入我们讨论的，还有我们刚才2位美国讲师，Professor Liu 以及 Dr. McFarland. Okay, over to you, Professor Liang.
Hey, thank you. So we'll now open up for full discussion. Any questions for the 3 speakers? But first, we do have one question from online. And it's a question from Yiling Cai. And it was saying that thanks to Dr. McFarland's great sharing. And you mentioned many collaborations activities in APEC. I'm wondering the feasibility of Taiwan participation in this. So could Dr. McFarland respond to this question, please? Can you hear us, Dr. McFarland? Yeah.
Oh, yes, thank you very much. I think my mute was locked, but now it is unlocked. Excellent, yes. So Taiwan is actually one of the most robust participators actually in APEC, and in particular the Life Sciences Innovation Forum and the APEC Health Working Group. Taiwan's Minister of Health actually is the chair of the APEC Life Sciences Innovation Forum Executive Board, and Taiwan actually leads a number of different initiatives within APEC, including on digital health and on other issues. So Taiwan actually has a very important role within APEC and is actually seen as a leader on health policy issues within APEC.
Okay, thank you very much. Other questions? Yes.
I'd like to thank all the speakers for their inspiring viewpoint on the health-related, financial, or societal perspective. I have a question for Professor Michael Liu. He has mentioned a lot about the shortcomings of the public health systems that we experienced in the pandemic. Because I'm from the Health Promotion Administration, a lot of our work has been delayed or even comes to a stop during the pandemic. So it is, we have a lot of impact on our work, and we really want to prepare for it for the future. I would like to ask Dr. Liu, what is your suggestion for us in the future if we want to prepare for the maybe the next wave of pandemic, especially for the preventive work? That is our responsibility. Thank you.
Professor Liu?
I think that's a great question. And it speaks to what we all know in public health, that the work of public health is often invisible until something really bad happens, like the pandemic, and we got to change that. We saw that in the United States, the funding for prevention goes up after after Ebola and after COVID. But then it's not sustained. And so I think a really important lesson that we can all take both in Taiwan as well as in the United States, is that we really need to be investing, governments need to be investing a lot more in prevention work, and to make sure that we're building up a strong national and global system for prevention, so that we are not trying to deal with all the problems afterwards. So I think now is the time to make sure that resources are not taken away from prevention and promotion toward addressing COVID related problems, but making sure that we're actually doubling down both in the United States and Taiwan on prevention work.
Thank you very much. Other questions?
Any other questions from the crowd?
Maybe I can ask one for Director Chen. And you gave a very interesting survey on the impact of the pandemics in Taiwan. And I'm just wondering that I think that looking back, especially in the last year, Taiwan been doing very well, other than the what I call public actions, by wearing a mask and washing hands frequently, and so on and so forth. But the other thing is the very tight border control. But the other side of the coin is that because of that, I think that probably have hindered the economic development. I was just wondering if in your survey, you asked the question how people feel about the policy of border control and how what their opinion about this.
We did ask similar questions to ask people whether they agree the government policies in very serious control, especially border control. Most of them agreed. So we are not surprised, but because in Taiwan, only a certain amount, a small amount of people needs to enter, need to have international travel. And then, so the majority of people in Taiwan still agree the border control in Taiwan. Even myself maybe thought it's better to have a little bit flexibility. But for the public, they are more in line with the government policies, so far.
Thank you. Other questions? Maybe I can ask a question for Professor Lu. And your presentation mentioned about the public trust was eroded in the previous administration. Now the new administration is taking the positions almost 1 year. What do you think? Do you think that they have regained the public trust? If that's the case, how so?
Well, I think what we're seeing now as a nation divided. I think we got half of the country that have really bought in to a lot of the misinformation and disinformation, and unfortunately with social media, that half of the country get most of their information from Facebook, from Twitter, so they kept getting fed the same misinformation and disinformation. I think it's really hard to try to restore the public distrust in about half of the country. I think for the other half of the country, there has been improvements. I think some of the kind of work that the Biden administration has been doing in terms of making sure that we're communicating trustworthy and transparent information, coming from the CDC, coming from the Department of Health and Human Services. I think some of the successes that we've had in terms of increasing vaccination, I think all of that have helped build up some public trust in many parts of the country, but unfortunately in other parts of the country, there's still a lot of mistrust and distrust. And that's why I mentioned that right now public health is fighting a losing battle. And until we figure out how do we fight misinformation, disinformation in the social media, I really get worried that we're going to lose a cultural war against science, against public health.
Thank you very much. And I think that the issue addressed is not specific to the United States. I think that that's true in many other countries as well.
Yeah, Professor Liang, we actually have one question from the internet saying that this member of the audience would like to know any role of social values, have been played into the response to COVID-19 in the United States. So maybe this is a question for two of our speakers from the US.
So may I ask Dr. McFarland answers first, followed by Professor Lu?
Well, thank you very much for the question. I think social values certainly does have a big role to play in health and health policy in general. As I would kind of agree with my colleague, within the United States, we do have a kind of a large difference in terms of social values, in terms of political alignment, in terms of kind of personal views. And so I think, unfortunately, that has actually affected the rollout of health policies, which really should be primarily science-based. And so I think social values certainly do have a huge role to play. And I think that certainly has had an impact on the United States' ability to roll out an effective health policy, but would certainly defer to my public health colleague to comment as well.
Great. Professor Lu?
Yeah, I think social values can definitely have a big role to play. The United States is a big country with diverse people and diverse values. Where I live right now in Berkeley, California, people care for each other. And I think very similar to in Taiwan, there's a strong value of communitarianism that I'm my brother's keeper, I'm my sister's keeper. I'm going to do everything to keep each other safe. And so I think we have a vaccination rate that's well in excess of 90%, and virtually when you are indoors, even when you're outdoors, people are masking, people are taking all the public health measures to keep each other safe. I can say that that's certainly not the case in many parts of the world, many parts of the country, where there's a strong sense of individualism, there's a strong mistrust and distrust of government, where people want to be left alone, and they don't think that they should be doing something that's being told, but in terms of whether they should get vaccinated, whether they should be masking, whether their kids should be masking in school and so forth, by authority. And so I think you do see a divided nation with very divided values right now, and I think that certainly impacts on the public's health.
We're talking about social value. I think right in the valley of Director Chen, so you'd like to chime in?
Yeah, I think social values are very important in Taiwan, as we know. Like in Taiwan, family has been playing a very important role in welfare safety, and Taiwanese are more obedient or more likely to be affected by the group pressure. So in this sense, Taiwanese wear masks, and so in this issue, I think in Taiwan, social values is a positive role in the prevention of the pandemic. But we know in Taiwan is a small country, and political values also play a role in the attitudes toward the government, even in the health policies. But that's another issue. Okay.
Thank you. I think we more or less run out of time, even though I personally have a few more questions we'd like to ask the speakers. So maybe can I just conclude by saying that I think looking back, we mentioned about the relative success in Taiwan in dealing with the pandemic, especially last year. I think there are many reasons. One being that I think that we took the lesson from the SARS experience in 2003 very seriously, and we actually made a great deal of changes. preparing for the future. Today we heard speakers share with us the lesson they felt they learned and how we can take from here. And some for short-term specific ones, such as the healthcare financing the roadmap of a longer period as well, such as the revitalize the public health systems. And so I think that the great deal that we can learn, not just ourselves, but the special government as well, preparing for the futures in case any other devastating pandemic as we have today in the future. So with that, please join us to thank our 4 speakers for their excellent presentation.
Yes, ladies and gentlemen, put your hands together for our speakers on site and online. Thank you again. And that's it for plenary session 2. And we're going to have a break right now. We'll be back by 10:40. And we'll be back to 3 parallel sessions going at the same time. Here, parallel session 9 on the impact caused by the COVID-19 pandemic on the social welfare system, or parallel session 7 on the 10th floor on poverty issues and governance response under the epidemic, or parallel session 5 on the 8th floor on how has COVID-19 impacted the sexual exploitation. 那接下来呢是我们中场休息的时间哦。那么等一下呢回来10点40分是会分成3场的平行场次，在我们的原场地呢是平行场次9。探讨的是疫情造成社会福利服务体系的冲击，或者是在10楼的平行场次7，主题是疫情下的贫穷议题以及因应，或者是在8楼的平行场次5，主题是疫情下的网络儿少性剥削变化。那接下来呢，我们休息一下，等一下10点40分再回到会场。Let's have a break right now. We'll be back by 10:40. Thank you.
谢谢 ，Thank you， 拜拜。
拜，谢谢。
哎，不好意思，我们控台可以帮我们放个简报吗？讲师想要稍微控一下那个简报往前往后这样。镭射笔，
所以还要跟
上面内容
观众互动。对对对，因为我来不及 underline 一些重点，所以我全部黑白的。就是我还没有，就是我没有时间去。
好，可以了，谢谢。 提醒各位贵宾，我们下个场次呢，准备要正式开始了，有请各位贵宾就座。Ladies and gentlemen, our next session will begin shortly. Please take your seats. Thank you very much. Welcome back, ladies and gentlemen. We're now in parallel session 9 on the impact caused by the COVID-19 pandemic on the social welfare system, hosted by the Social and Family Affairs Administration Ministry of Health and Welfare. 那欢迎大家呢继续回到我们平行场次9，由社会及家庭署所筹办的这个场次呢，我们主题是放在疫情造成社会福利服务体系的冲击。那我们场次的一开始呢，就首先有请我们场次的主持人，国立台北大学社会工作学系张金芬副教授。Please join me in welcoming your moderator, Dr. Jingfen Zhang, Associate Professor of Department of Social Work, National Taipei University, Taiwan. 掌声欢迎。
Hi, good morning. Yeah, dear participants, it's my honor to chair this session and introduce 4 speakers. Present the impacts of social welfare by COVID-19 pandemic. From 2020, the COVID-19 pandemic has swept worldwide. Researchers told us vulnerable groups have suffered more. Viewing globally, governments try to have social welfare programs to subsidize everyone in need. Enhance the impact of COVID-19 on 4 vulnerable groups: middle-aged women, child and youth, people with disabilities, and older people will be presented in this section. The first speaker is Hong Hui Fen. She is a full-time professor in Department of Social Work in Soochow University. She is very concerned about the issue of women and care. The topic of Professor Hong will present is the emotional labor and family care burden of Taiwan middle-aged women under social distancing policy of COVID-19. Let us welcome Professor Huang.
Thank you, Dr. Zhang, for the introduction. It's my topic, the emotional labor and family care burden of Taiwan middle-aged women under social distancing policy of COVID-19. The operation of contemporary capitalism has intensively relied on the public-private separation between production and reproduction. However, the social distancing policy under COVID-19 has made great impact on such separation. The empirical studies in other countries suggest that When the public productive activities have been taken back to the private life space, women's burden of emotional labor and family care will sharply increase and has the interlocking negative effect on their employment. The vulnerabilities in Taiwan include the caring arrangement of Taiwan is of high familism and commodification. The work organizations are inflexible for caregivers, which may cause our women trapped into a more difficult situation. Thus, I used the qualitative interview contests of 7 Taiwan middle-aged women to answer the following 2 questions. 1, how had they responded to the increased domestic labor during the outbreak of COVID-19? What effects on their employment? I had 2 conditions for interviewees. 1, females aged between 45 and 64 years. 2, those who take care of the families or relatives under 18 years old. Considering the intersection of gender and class, the interviewees must include some middle-aged women without college degree or living in non-urban area. It's a profile of 7 interviewees. All interviewees are in heterosexual marriages. C and D are in cross-national marriages. C's husband was from Europe, and they met and got married when C was studying overseas. D was a typical marriage immigrant coming from China. The difference in their marriage reflected the intersection of gender and class. 5 younger middle-aged females are interviewed. Besides B, the other 4 interviewees took a dual breadwinner model. 2 senior middle-aged females were interviewed, E and F. I had 3 findings as follows. First, although 5 among 7 interviews had taken a dual breadwinner model, only S and C's husbands could share housework and parenting more equally. Before COVID-19, there has been the unequal gender share of domestic labor. Thus, under the social distance policy, the increased housework and care burden continuously fell on the females interviewed. All 5 younger middle-aged females interviewed have been bound tightly by the gender norm of intensive mothering. When children enter the primary schools, monitoring children's homework and exam performance have been treated as the most important parenting task. Besides C, such horrible tasks have been taken by the interviewed mothers. Female employment could contribute males' equal share of housework and parenting, but the gender norm of female caregiver would decrease such contribution. In the cases A and C, we could see the positive effect of female employment. But in the cases G and D, we also could see the negative effect of the gender norm of female caregiver. The dual breadwinner model in Taiwan has been deeply based on the cross-generation collaboration of care work for children. A, B, and D had more or less used the informal support from the families of origin to solve the dilemma between work and caring for children. Such informal support from the original families was low cost, but had damage to the well-being of the interviewed senior middle-aged females. The second finding was that the caregiver unfriendly labor market had worsened the gender inequality under social distancing. Overtime work had been the universal organization culture in Taiwan's companies. In the case of A, even if husband was willing to share equally the caring burden with wife, The inflexibility of work organization would prevent him from equal parenting. C and G was employed in non-competitive sector. C was the college teacher and G the high school teacher. During a period of social distancing, they both worked from home and had much flexible time to accompany their children and arrange extracurricular activities when children stayed home. C, as a college teacher, had flexibility to maintain work-life balance, but she also mentioned that she felt guilty and uneasy about her poor research performance. It's a flexibility stigma. But the elite women must face the cultural contradiction between flexibility, stigma, and intensive mothering. A was employed in the competitive sector. In many work organizations, time remains the most important indicator for the performance of employees. According to A, if one might need COVID-19 family leaves to take care of their children, no one would really ask for leave. Why? A told me, who knows how your supervisor evaluated you? The model of work from home in Taiwan was also inflexible. The technology of remote work had made the work, including employees' family life, resulting in longer work time. D was employed non-standardly, being treated as self-employed and paid by pieces. During a period of level 3 alert, he had no income, which made her economically dependent on her husband, taking more housework and carrying burden than before. Finally, many interviewees mentioned that during a period of social distancing, all family members work together and live together, just like all take a 3-month vacation, and they cherish such vacation very, very much. The universal work time overtime work culture in Taiwan's company had made employees trapped into the time poverty in family life. The third finding was that the challenge to gender inequality involved emotional conflicts. Accordingly, the gender norm of female caregiver might be one kind of cultural habitus that had been deeply embedded into the interviewee's mind and self. Hence, if the interviewee attempts to challenge such cultural habitus, she might suffer strong emotional conflicts with her significant others, such as husband or mother-in-law. Under a gender norm of intensive mothering, being a good mother involved the emotion management, which Hochschild called mothers were expected to keep family in comfort, which was viewed as being healthy for children. When arguing for more equal parenting, the emotional conflict will destroy the peace within a family. It's the emotional labor. As Hochschild suggested, depressing one's real feeling would make one isolate from her own deep emotion, and then abstract her far from the self. My concluding remarks are: 1. Under the social tendency of dual breadwinner model, the gender role revolution of female caregiver has been stalled. It's because of the underdevelopment of public child care service and the inflexibility in work organization in Taiwan. 2. The social distancing had not made the gender inequality worsen too much. However, if considering the difference in class and generation, the working class interviews such as D and the senior interviewees such as E and F were the ones who had suffered more. It's the end of my presentation. Thank you for your time and attention.
Thank you. Thank you for Professor Hong. Under Professor Hong's presentation, we learned more on how far the COVID-19 caused the emotional labor and the care burdens for middle-aged women. The second presenter is Zhong Zhe-in. he is employed as Superior Specialist, International Development Division, Taiwan Fund for Children and Family. The topic of Mr. Zhong will present is adaptation of child and youth service delivery under COVID-19. Let us welcome Mr. Zhong.
Okay, thank you, Professor Zhang. And it's very great to be here and share this topic to all of you. And today's topic I want to share is adaptation of children and youth service delivery under the COVID-19. Maybe this topic is not professionals than others, but Professor sharing, but I think this is our working experience during this pandemic period. And this topic is more practical, and we will focus on social work practice and also the welfare service during this period. Okay, and first of all, I want to introduce our organization. We call Taiwan Fund for Children and Families, also called TFCF. We are a non-governmental organization, provide the support for vulnerable children and their families. TFCF, we have a global service, including the poverty issue and children protection, capacity building, and community development, also the early intervention for children with disability. And this map is told us where we work. We have domestic service, supports around 60,000 children with 24 domestic branch and 40 service center. And our overseas service supports almost 67,000 children with 7 overseas branch office and 34 dedicated projects. So during the pandemic, we have some finding. Here have 3 findings we can find through our daily work. First, we'll focus on the social welfare support. And the second, we'll focus on family economics. And the third is about the schooling. We do some research. We also want to know how the pandemic affect our advantaged families. So this is the research from conducted by World Bank. They use the phone surveys and collect the data. This survey is called Household Monitoring System to track the impact of COVID-19 pandemic. So this surveys show that 36 of those workers prior to COVID-19 stopped working during April to July 2020. And 62 of household reports reduction in total income. An average of 51% of households in IDA country reports one adult skipping at least one meal due to lack of resources in last 30 days. The IDA country here is mentioned International Development Association. Is the country the World Bank usually work with to face the poverty issue. We used to call them the developing country or low-income country. And less than 30% of households with children who attending school prior to the pandemic complete an educational assignment since the outbreak. And second resource from Save the Children. Save the Children is an international organization like us. They publish the survey called the Hiding Impact of COVID-19 on Children Poverties. They collect 17,565 parents, caregivers, and also over 8,000 children from 37 countries surveys. those participants who are received the service from Save the Children. So the results might be more close with our curious, the advantaged family situation. So the results show that 77% of households report an income loss since the start of the COVID-19 outbreak. And 81% responders struggle to pay for the food. And 43% were stressed, and 36% were extraordinary stress, or in crisis have minimum food insecurities. Half of the children do not have access to learning material which were previously provided by school, as well as meal or sanitation product. The children report that their care duty towards siblings or others have increased, and the child burden have increased compared to COVID-19. We collect these results and pursue the research. This research, and we think there are 6 types of difficulty and challenge affect our advantaged families, like family finance, physiological needs, and mental health, children development and learning, and family relationship and social support. With this result, we think we also want to know how the situation in Taiwan. So we plan this domestic surveys at middle of August this year. And this survey's purpose is understand the effect of COVID-19 on our sponsor families. So we collect 1,700 more data to show the results is here. First, it's about family finance. It's over 85% of disadvantaged family in economic hardship due to reducing working hours or employment. And in physiological needs, over 66% of families suffers from insufficient dietary supply, and over 69% of family members have clinical disease, in which 70% have had trouble to receive the medicine. And next is about the mental health. Over half of our sponsor children and youth have experienced negative emotion during the quarantine period. And about the child development and learnings, it's almost 70% of family respond the online learning have affected the children's academic performance, mainly because no fixed learning schedule and the parent lack of the online learning skill. It's around 70% of children requires early intervention, in which 62.5% have had effect. And the family relationship parts, over half of the parents, they experience difficult in caregiving during the school closure. And 43.7% of parents and children report an increase in conflicts. For social support part, 44.7% of children respond that negative effect due to reduce the interaction with peers during the quarantine period. With these results, we develop our search for domestic family. And here we have 3 different parts of our domestic strategy, including the financial support program, including the program called Emergency Relief, and in pandemic prevention material and living supplies. And about the social support programs, including the online interaction with children and families through the individual and group activity. And we also conduct an online tour bus during the pandemic. And about the learning programs, including the e-learning resource equipment and internet feed, and online tutoring service. Also, the digital learning platform, resource matching. Besides the domestic strategy, we also provide the overseas strategy for COVID-19. We call it RIMS. It's including the reduce the infect risk of family members and increase the immunity of the beneficiary, mitigate the economic and psychological pressures of family, stress and develop the community network. The strategy overseas, we do understand the situation is totally different than the national level. So our strategy overseas will be more macro. Here is our 5 main projects to respond to the pandemic. During the pandemic, we reached over 97% of our sponsor family, and we dispersed over $500 million to respond for whole worldwide. Here is the conclusion that show the future vision and view to respond and coexist with the COVID-19. First is about the digital social work. We know the technology is very convenient, so for social worker or staff, they need to build the ability to use the technology with our beneficiary. And the technology, we also believe, can bring more interaction between the parents and the children. And second is about the social service delivery assurance, because during the pandemic, different extent of quarantine policy influencing our service delivery. So we believe community network and technology is the key of stability. And the third part is about resilience and innovation. To respond to the pandemic, clear strategy can bring clear purpose of the projects, and the project can give us positive outcome and impact. The projects, because during the pandemic development and policies always change, so the resilience and anger's response will be the key for us to running our projects. And the last one is about the human orient. The projects under the COVID-19, not just based on the needs of the beneficiary. We also need to think about based on human orient, and we can provide more service for our beneficiary. Here is my presentation. Thank you.
Thank you, Mr. Zhong. Under his presentation, we learn more on the survey to find the disadvantaged families have suffered on economic, healthcare, and loneliness. Social workers tried to combine services by digital and face-to-face. I think it's a good chance to let us learn more about this. And the third presenter is Lin Zhao-Yin. She is Associate Dean in College of Social Sciences, Professor and Director in Department of Social Work, National Taipei University. Professor Lin concerns the issue of disabilities, social and health policy, and NHI. The topic of Professor Lin will present is protection of health rights for people with disabilities during COVID-19 pandemic in Taiwan. A disability inclusive perspective. Let us welcome Professor Lin.
Okay, hello, good morning, dear ladies and gentlemen. So today I will going to give a presentation about the protection of health rights for people with disabilities during COVID-19 pandemic in Taiwan, a disability inclusive perspective. So, okay, so different from the other two presentations. So so far we didn't have very much empirical studies or statistics about people with disabilities during the COVID-19 pandemic. So today I will give the presentations with some kind of international guidelines to give us some directions how to protect the healthcare rights of disabled peoples. So first, I would like to highlight the trend of the pandemic in Taiwan. So actually, I have given a presentation about these topics in February. So it's mainly about the social economic situation of disabled people during the pandemic. But in February, so in February, so we have very low rate of cases. So now, since the middle of May, so we have very big increase for this pandemic. So that's why I had a similar presentation, but under totally different situations. Therefore, I have to think again about how the implication of this pandemic for the disabled people. So, on 21st of October, we have 16,349 confirmed cases, and 846 people dying due to the disease. But how about the people with disabilities who have got years or been confirmed cases or been quarantined? So we have very little, or even die due to the disease. We have very little statistics about this, about the people with disability. So far we just can see the distribution of genders and areas for all these confirmed cases. So that's why we probably need more analysis about these confirmed cases. And so, as I said, I will just show some international guidelines for the protection of healthcare rights for disabled peoples. So actually, in other countries, the issues or the pandemic have more severe impacts on general people as well as people with disabilities. So they have a lot of publications or websites or web pages and so on to provide all this kind of information for different types of disabled people. But first, I will just show some general guidelines from the CRPD. So I will just highlight some, especially in the Article 25, so which talk about the health rights. So it means that state parties should take all appropriate measures to ensure access for persons with disability to health services. So, and how to do that? So the A means that we should provide persons with disability with the same range, quality, and standard of free or affordable healthcare and programs as provided to other persons. So, and in the item B is that we need to provide those services needed by persons specifically because of their disabilities, including early identification and so on, and provide these health services as close as possible to people within their own communities. And so we require the health professionals to provide care of the same quality to persons with disabilities to others, and to prohibit discrimination against persons with disability in the provision of health insurance, and to prevent discriminatory denial of health care or health services of foreign friends on the basis of disabilities. So these general guidelines told us that we should provide similar healthcare services for general persons as well as for disabled persons. So especially focus on 4 criteria. The first one is accessibility, availabilities, and affordabilities, and the qualities. So we can use these guidelines or principles to examine or to look at what we have done for disabled persons during the pandemic. So later, I will just focus on these 4 principles and to examine why, how about the situations in Taiwan. So the second one is from the International Disability Alliance. So last year, there was an outbreak of the pandemic abroad. So this international organization issues many guidelines or recommendations for the government or NGOs. And I and another 2 professors, we have translated these guidelines or these 10 recommendations. So it means that toward disability increased COVID-19 response and 10 recommendations from the IDAs. So I think these guidelines could provide some suggestions for our government to think about the healthcare policies for disabled peoples. So first, it means that persons with disability must receive information about infections and mitigating tips and public restriction plans and the service offered in a diversity of accessible formats. So we can think about whether we have provided sufficient and accessible information for disabled peoples during the pandemic. And the second one, additional protective measures must be taken for people with disabilities with certain types of impairments. So far, we know our government has during the press conference every day by the CDC. So we have persons to use the sign language for hearing disability people. But how about those with visual impairments or mental and intellectual disabilities? So we should also provide some similar information or explanations for different types of impairments. And the third one is all preparations and response plans must be inclusive of and accessible to women with disabilities. So the gender is also important issues. And no disability-based institutionalization abandonment is acceptable. And during the quarantine support services, personal assistance, physical and communication accessibility must be ensured. Measures or public restrictions must consider persons with disabilities on an equal basis with others. And the third one is persons with disabilities in need of health services due to COVID-19 cannot be deprioritized on the ground of their disabilities. Yeah, for example, now we have the policy of vaccinations. So we should think about the priorities of disabled persons to get vaccinations. And the last two is about the OPD. That means organizations for persons with disabilities. So these organizations can ensure play key roles in raising awareness of persons with disabilities and their families. And OPDs can ensure play a key role in advocating for disability inclusive response to COVID-19 crisis. So we are glad that our government look at or pay attention to disability inclusive policies or response while taking any measures to combat the COVID-19 pandemic. And the next one is from the Center for Disease Control and Prevention from the USA. So they also have some guidelines and a lot of information on the webpage. So you can check the webpage yourself and just highlight that they think people with disabilities are not more likely to become infected with or have severe illness from COVID-19. However, these people might be more likely to get infected or have severe illness because of underlying medical conditions. So for some people with disabilities, they have some chronic conditions, and which is related to the likelihood of severely ill from COVID-19. Therefore, we should pay more attention to adults with disabilities. They said that adults with disabilities are three times more likely than adults without disability to have heart disease, diabetic, cancer, or stroke. And because of these chronic conditions, they could be more vulnerable from the infections. And the second one is from the CDC that they talk about if people have one of the disability types listed below, they might have more likelihood to be infected. So for those people who have limited mobilities or who cannot avoid coming into close contact with others, like direct support providers and family members. As we know, in Taiwan, we have caregivers for disabled people. So, and if the caregivers, doesn't matter formal or informal, from the formal and informal systems, they have very close contact with disabled people. And if they have been infected, they also influence the life of these people a lot. And also, if people who have trouble understanding the information or practice preventive measures, for example, they have problems of keeping social distance, or they have to touch everything for like visual impairments. They have to be familiar with the environment by touching the environments. So they have problem of keeping, they have problem of washing their hands all the times. So like, for example, like disabled people who have this kind of specific issues, so we should pay more attention how to help them to prevent from the disease. And also for those who cannot communicate well with other peoples. So these are also the issues. And also from in the United States, they have focused about the immunizations for people with disabilities. So they have surveys like from the national immunization surveys, and they have discussions that people with disability had a lower likelihood of having received COVID-19 vaccinations. Yeah. So, and given that they are less likely to report hesitance about getting vaccinated. So they are not hesitant to get vaccinated, but they have a lower rate of being vaccinated. So that's what's the situation in Taiwan so far? We have very, very limited information from our government. So maybe we should have some more research about these issues. And finally, I just look from the international guidelines and what's the impact of COVID-19 on healthcare situations of disabled people in Taiwan. For example, from the first principle of accessibilities, because we don't have any evidence, so I got these ideas from from the newspaper or reports and so on. So some disabled people say they have problem of purchasing facial mask and also going to the primary clinics, because during the pandemic, they are not very encouraged to go to the big hospitals. So they have to go to primary clinics, but they also face the problem of barrier-free environment. And also some reports about a lady who who was suspected as confirmed cases and stay in the negative pressure wards. And she found that it was not very comfortable to be in the negative pressure wards because they don't have barrier environments, and the caregiver was not allowed to go to the negative pressure wards with her. Okay, so, and also they have also some problem with the affordabilities, because these people, they need extra expenditures for buying personal protection equipment, which might be economic burdens for some disabled persons. And so they also have some extra expenditure for COVID-19 tests, such as PCR, because if you want to go to the daycare centers or any nursing home, this kind of institutions, you have to be vaccinated or you have to get a lot of tests. And also about the concerning about the qualities of care, concerning the quality of medical cares. So we think we have to focus. We also have to pay attention to the mental health of people with disabilities. And during the pandemic, they need intensive support from the families. So I think this is similar from the first presentation by Professor Hong, really talking about the issues of families during the pandemic. So last one, I think, in the end, I really want to have, we really need more analysis and more informations about how about the confirmed cases of people with disabilities, because due to the lack of these related demographic statistics, we cannot have any kind of plan or measures to cope with these issues. And also, as we see that the life of people with disability have been directly or indirectly influenced by the pandemic. So apart from the economic impacts, the social and psychological impacts should also be concerns. And we should think about the accessibility of health information and their level of psychological well-being. So, and that is my presentation, and thank you for your attention. Thank you.
Thank you, Professor Lin. Under her presentation, she reminded us the health rights for people with disabilities during the pandemic in Taiwan. And we need more research in this field. The last presenter is Yamagishi Daisuke. He is President, Representative Director in Long-Term Care Service Company, Japan. The topic of President Yamasuki will present is reporting our handling of COVID-19. President Yamagishi will use Japanese to present this section. Vice Executive You Ruyu, YMCA in Tainan, will be interpreter for this presentation. Let us welcome President Yamagishi and Vice Executive You. Welcome you.
山岸さん、また聞こえませんですから、どうぞ、マイクをオンにしてください。そうですね、今現場に、山岸さんの声を聞こえませんですから、まだ聞こえません。是由他那边控吗？还是？すいません、どうぞもう一度、チェックしてください。
これでどうでしょうか。
はい、はい、もう大丈夫です。ご講演よろしくお願いします。
よろしくお願いします。恐れ入ります。皆さん、こんにちは。日本語にて失礼します。生活介護サービスの山岸と申します。
大家
Ladies and gentlemen, good afternoon. My name is Daisuke Yamagishi. I'm the president and representative director of Seikatsu Kaigo Service.
本当にありがとうございました。
I would like to thank the organizer for giving me this opportunity to talk to you. This January, there was a cluster infection in the nursing home. Our staff and half of the staff and the people in the nursing home were infected. From the beginning of the infection until the incident has ended, there was about a month that passed. Next page, please.
ネクストスライドをしてください。
私の方でですかね。
そうですね。はい、お願いします。
すみません、動かないですね。
動かないですか。
OK。
OK ですかね。
はい、もう OK です。
続けます。最初に会社紹介をさせていただきます。
那首先我先介绍我们的公司。
Let me introduce my company first. The name of the company is Seikatsu Kaigo Service Company. We have been established for more than 22 years. We are providing care service and medical services. Currently, we have 240 people. There were Filipinos. 10 of them are Filipinos.
Ah, すみません、山口さん、また、声を聞こえませんですから。はい。
これでどうですか。すみません、
はい、今大丈夫です。
会社の理念はこの通りとなります。私たちが利用者様とご縁をいただき、一緒の時間を過ごさせていただく際に大事にしていることは、ナーシングホームのルールに合わせてもらうのではなく、ご利用者様の生活歴を大切にしています。
The philosophy of the company is that we focus on the rights of those in the nursing homes. We will not try to enforce our values on every individual. We respect their habits.
考えております。
Therefore, it is important for us to learn about the living styles of each individual so that when they're in our nursing homes, they can continue their own lifestyles.
次のスライドお願いします。それでは今回クラスターが発生したナーシングホームをご紹介します。
Now let me talk about the nursing home where the cluster occurred. This happened in this building. It's a 2-floor building. There were about 18 people living there at that time. The staff were all nursing staff providing care. There were no medical personnel stationed there.
皆さんご利用者様は認知症診断があります。
So most of the people living there had dementia.
次のスライドお願いします。これは施設の写真です。グループホームは利用者様が少人数で生活し、家庭的な雰囲気で生活をする場です。
Here are some photos of the facility. So you can see from the photos that there aren't a lot of people. We try to create an atmosphere where it's somehow like a home, living in a home.
普段であればいちご狩りに外出しに行くところですが、コロナ禍で行けませんでした。そこで工夫をし楽しんでいただいてます。
Usually, people can go outside on their own. They can move around freely, but during the COVID-19 pandemic, we cannot allow them to go outside. So therefore, we need to provide them with more activities in the nursing homes.
次のスライドお願いします。それではクラスターについて3つに分けご報告いたします。
And for the outbreak this time, I would like to divide it into 3 parts.
最初に1人目の陽性者が発生した日から延べ21名がコロナウイルス感染症感染いたしました。
So there were 21 people infected. There were people who were discharged and 2 patients passed away. When people were diagnosed positively, we had to send them for hospitalization, but because there was a 3rd wave of the disease, therefore they could not be hospitalized. "11 patients were tested positive, and only 4 were able to be hospitalized. And as for the situation of the staff members at that time, there were family members that that the family members living together with the staff members, so we need to consider this situation as well. So I would like to talk about the mental state of the staff.
次のスライドお願いします。当時日本は第3波と呼ばれ、1日約4000から7000人程度の陽性者が発生していました。
At that time, Japan was experiencing the third wave of the outbreak, and there were about 4,000 to 7,000 positive cases per day in Japan.
国のガイドラインでは、高齢者施設の利用者はコロナウイルス感染症陽性となった場合に、すぐに入院調整を行うという指針がありました。
According to the national guidelines, people in elderly care facilities, if they're tested positive, they need to be hospitalized for treatment immediately.
しかし、この多数の陽性者発生にうち、保健所による入院調整は非常に困難になっていました。
However, because there were so many people infected at that time, so although we wanted to follow the national guidelines, however, it was very difficult because it was very difficult to send them to the hospitals.
次のスライドお願いします。
下一片。
施設内関係者40名のうち、感染者は半数以上の21名でした。
整个机构
In the facility, of the 40 people, 21 were infected. And within the first week, 17 people were infected. Of the 10 staff members, 1 were tested positive. Because we did not have a lot of staff members, we had to borrow staff members from other facilities for support.
当時の写真をいくつかご紹介いたします。
介绍当
Here are some photos from that time. On the left-hand side, you can see one of the nursing staff. They had to wear personal protective equipment. On the right, you see the alcohol spray and the disinfectants. These were used for protection. There were many of them because they were placed everywhere in the facility. We placed them in many places, so you can see the setup was placed in many places in the facility. Here, you can see oxygen concentrator, oxygen provider, and refrigerators. We thought that there might be a sudden drop in the oxygen saturation level, so we have installed these oxygenators in many places within the facility. in emergencies, we want to make sure that our staff will not panic and forget what to do. So on these machines, we have pasted different signages and instructions. In the refrigerators, there are no food, there's only drinks. At that time, we did not have enough staff. So there were no staff to prepare meals. At that time, we couldn't prepare meals. We only served lunch boxes.
施設のリビングの写真です。
那这是那个
This is the living room in the facility. Usually, our living room is often used by the elderly. However, during the pandemic, especially for patients with mild symptoms, sometimes we want to let them know that we need to make sure that they don't come to the living rooms. A lot of times, people with dementia would not wear masks, and they would come out of their own rooms. So it was necessary for us to convince these dementia patients to not come to living rooms. You cannot force them to do something that they don't understand. Therefore, we need to think about other ways to guide them so that they will stay in their own rooms. So what we did was that we drew down the curtains, although it's actually in the day, and we turned off all the lights.
これはフロアのトイレへこのような張り紙をしました。
那在
In addition, on each floor, we also put up these signs in the restrooms. We hope that the patients can return to their own rooms, so we had to introduce these measures. And in each floor, we do disinfect the restrooms every hour. So we posted this sign telling them that we are now cleaning the restrooms and our patients can understand, so they would return to their own rooms.
私どもの法人方針はこの3つです。
那我们法人的方针有
Our corporate policies include the follows. First of all, we want to make sure that all the patients and all the staff members have a correct understanding of COVID-19, and so that they would not be afraid. They know, well, they actually have to be careful. Within the facility, if there are positive cases, then they would be monitored. In practice, if there's close contact, then we want to make sure that there will be no further contacts and reduce contacts as much as possible.
陽性者発生時の初期対応をまとめましたが、これからテーマごとにご報告いたします。
When there are positive cases, we would respond with different measures, and below are what I'm going to talk about.
次のスライドお願いします。
下一片。
最初に職員体制についてです。
那首先是那个
First of all, the principles that staff need to abide by. When there were positive cases, we have to make sure that within the schedule, who were able to work. However, because within a very short period of time, within 1 week, positive cases grew dramatically, so it was very difficult to have available staff. First of all, we need to move staff members from other floors who were able to work. But even if they were available, but staff members opposed being moved to these floors because they don't want to face such dangers and risks being infected. So we need to borrow 5 staff members from other facilities to help us.
次は医療連携です。医療連携は伊良原診療所が一手に引き受けていただきました。
We worked with medical facilities. We worked with Irabara Clinic. We work with medical clinics, and so when there are positive cases that occur during the night, then the clinic would provide PCR testing the next day. The doctors in charge provided online medical care using a tablet every day, regardless of whether he was on vacation or not. The law did not require us to have medical staff in the facilities, but because of this linkage with medical clinics, so it was very helpful for our facility. They were able to support us greatly.
下一片。
すみません。この次のスライドお願いします。
下一片。
次に情報共有です。
那接下来谈那个
Next, I would like to talk about the dissemination of information, sharing information. When there was the cluster infection, we had to call many places. Usually, there were not many tasks, so we only had one phone line in the facility. Usually, the caring staff might have phones coming from the outside. When the pandemic happened, we started to place cell phones in each floor. In addition, we also started to use group chats within the Line app. The Line chats were very available because we had not only text but also images and videos when necessary.
これがその時の情報共有で使ったツールです。左手はグループ LINE の写真、右手は携帯電話です。
那这就是刚才说明。
Here you see the Line group chats and also the setup of the cell phones in each floor. This is my last slide. Within the corporation, if we want to achieve 0 infections, I think that is actually impossible because there are a lot of connections between various facilities. So nearly 1,000 people were affected. So I think what is important is to control the number of people infected, and we need to make sure that everybody has the right understanding of the pandemic and prevent the infection from spreading. I think what was really challenging was that within a short time span, we need to ensure that information can be shared. I think this was what was the most challenging part. In the past, we did not use these group chats, but because of the COVID-19 pandemic, our corporation introduced SNS, and we also think that it was very useful, and in the future, we will continue to use this function. The cluster infection was, of course, very challenging, but we were supported with a lot of substantial assistance and supplies from within and outside of the company. And we were very thankful that during the process or during the incident, within the corporation or within the community, everybody was very supportive. Everybody worked together to solve this crisis. Thank you very much for your attention.
山岸さん、ありがとうございました。
ありがとうございました。
谢谢三安社长还有尤副执行长在疫情。
Thank you very much. So just now he had shared with us their experience with taking care of their residents during COVID-19 pandemic. So I would like to invite Mr. Yamagishi to remain online because we will be proceeding with our panel discussion. So at this point, we would like to invite all speakers to take your seat on stage.
Discussion に移りたいと思います。We'd like to invite all of our speakers and also moderators to have a seat on the stage. We're going to move on to the panel discussion right now. Let's welcome Professor Hong, Mr. Zhong, Professor Lin.
We collect 2 questions because time limit. Is there anyone want to ask a question in English, Chinese, or Japanese? It's all welcome. You can raise your hand.
各位贵宾要用中文、英文或日文提问都可以哦，看大家有没有任何问题。Any questions?
Yeah. Any questions for speakers and for papers? Yeah. Oh, yeah. Okay. Professor Lin.
我只是想要问刚刚那个日本这个个案哦，因为他们其实大概有一半的人是有感染的嘛，然后另外有一半是职员，有一半是就是住民。我想知道他们后来的发展的情况怎样？譬如说他们有成为重症吗？然后他们有恢复的情形是如何的？然后就是住民的情况跟一般的职员他们的恢复的情况是有不一样吗？例如说住民可能会非常严重等等。那第二个问题是因为他们在那样的情况底下，好像是跟外界的关系是有等于是断绝的。那在这个情况，这些住民他们的心理状态是如何的呢？因为他们可能没有家人拜访啦，或者是等等，或者是有些担心，还是说他们其实跟一般的情况没有什么差别？以上。
山岸社長、質問2つあります。1つは先ほど1週間のうちにもう半数以上の感染者が出ていまして、質問としてはその後住民と職員スタッフの回復の期間はどのようにそのプロセスもうちょっと詳しく述べていただけるでしょうか。2番目はクラスター中の外との関係はやっぱりちょっと中断されているので、その辺住民の心理的な影響はあるでしょうか。例えば普段は家族が訪ねることできるのはもうできなくなって、その辺の工夫は先ほどの報告以外にまた何かありましたらどうぞ、シェアしてください。
はい、山岸さんまた聞こえませんでしたから、マイクをチェックしてください。また聞こえませんですから。はい。是他那边要开，是不是？不好意思，日本讲者这边好像现在网络有点。はい、今声は大丈夫ですけれども、でも画面がないですから。
画面がないですか？すいません。これでいかがでしょうか？
はい、もう大丈夫です。よろしくお願いします。
お待たせいたしました。すいません。では、まず最初の回復の期間のプロセスなんですけども、今回ですね、職員の方については、皆さん、陽性になってから、大体10日間を経て回復しております。
員工的部分大概
Well, in terms of staff members, most of them recovered within 10 days. Well, some of them actually stay home to engage in self-monitoring of their health status, but some of them had to stay at hotel.
療養中の安否確認の方については、保健所だけではなく、私の方でも毎日電話をしております。
Well, so I was the person who were in constant touch with the authorities in order to help monitor the health status of our staff members.
職員によっては一人暮らしの者もいたので、できるだけ孤独にさせないことが重要だと思っていました。
So among the staff members, some of them actually live alone. So I also have to pay attention to the emotional state of those staff members who were living alone.
利用者様については、日々施設の方で療養をしておりました。
Well, in terms of our residents, so we have resident doctors. So during that period of time, our medical staff would visit all the residents who had been infected.
急激に様子が体調不良になるよう
So again, if their symptoms got worse, I would contact the authorities to check to see whether they needed to be hospitalized. One more thing, well, because you asked about were we able to stay in touch with the outside world. Well, so basically, because we were covered by local news media.
その際に地域の方がびっくりしないように、あらかじめ私
Well, because there was news coverage of our institution, and in order to prevent community members from getting panicked, so I had to try to communicate with members of our local community.
地域の方は非常に温かく、批判するような方はほとんどいませんでした。
So, as far as members of local communities concerned, they actually were quite nice to us. They didn't criticize our institution.
一方では、ご家族の方については、あらかじめそのコロナ禍において面会を禁止していました。さほど影響はありませんでした。
So, because we had a cluster of infections, that's why we didn't allow any family members to visit our institution.
一方で、新聞報道
Well, because we were covered in the news, therefore, many people actually called in to our institution. That's why we had to answer a lot of phone calls.
最初は電話一つ一つ対応していましたが、先ほどもお伝えした通り、非常に多くの方との連絡があったので、後ほどそこからは SNS を使い連絡の手段を取っていました。
Well, initially, there were so many calls coming in. Therefore, we needed to use SMS in order to cut down on the number of phone calls coming in.
もう一つ、業者の方なんですけども、業者の方に情報が伝わらず、施設の中の近くまで来てしまうようなことがありましたので、それはそこでちょっと声かけをさせていただいて、中に入ることをやめてもらいました。
Well, some of them actually came to our institutions without calling first, but we had to explain to them why we restricted visitation.
以上です。ありがとうございました。
謝謝。
So, that was my response to the questions.
Shall we close this section? Maybe you have other questions, so we will collect maybe after a conference, or you can contact two speakers. Thank you very much. Thank you.
Once again, a big round of applause to all of our speakers. ではパネルを終了いたします。山口さん、本当にありがとうございました。好，我们非常谢谢今天的我们的主持人以及讲师哦。那接下来呢，就是我们中午休息的时间了。我们休息到下午1点半，休息到下午1点半。Ladies and gentlemen, we're going to have a lunch break right now, and when we come back at 1:30. Here, it will be parallel session 10 on the digital reform of national health insurance for combating COVID-19. Or you can go to the 10th floor for parallel session 8 on health, workforce, and people-oriented care. Or the 8th floor, parallel session 6, mental health issues during the pandemic. 那么1点半回来的时候会分成3个平行场次哦，在我们原场地呢是平行场次10，主题是科技防疫、全民健保的数位改革，或者是到10楼。平行场次8是健康照护人力与以人为本的照护，或者是到8楼的平行场次6。疫情心理健康。So we have lunch boxes ready outside. Please help yourselves, and we'll be back by 1:30. See you in the afternoon. Thank you. 各位贵宾，我们的下午场次呢，再过2分钟之后会正式开始，请各位贵宾呢再稍后一下，也提醒您记得将手机转为震动或静音。非常谢谢各位贵宾的配合。Ladies and gentlemen, parallel session 10 will begin in 2 minutes. Please take your seats and kindly turn your mobile phones into vibration or silence mode. Thank you. Ladies and gentlemen, welcome back. We're right now in parallel session 10, Digital Reform of National Health Insurance for Combating COVID-19, hosted by the National Health Insurance Administration. 欢迎大家呢回到我们的会场啊，我们目前所在的是平行场次10，是由健保署所负责筹办的。那我们的主题呢是科技防疫全民健保的数位改革。And now, let's begin by having our moderator and also the first keynote speaker of this session to the stage. Please welcome Dr. Bo Zhang, Lead Director General of National Health Insurance Administration, Ministry of Health and Welfare. 让我们有请我们的主持人，同时也是第一位讲师，我们健保署的李伯章署长。署长有请。
Okay, distinguished guests, ladies and gentlemen, yeah. And some audience from the online, yeah. You're welcome to join this afternoon symposium, yeah. Basically, I'm the Director General of the National Health Insurance Administration in Taiwan, yeah. And today, our topic is talking about the combating of the COVID-19 during this area, yeah. I want to say that in the past, yeah, maybe we treated the patient just, very simple. But today, the situation is quite different, yeah. And I'm the surgeon before, yeah. So I think it's something we should be very, very careful how to choose the best way to treat the patient, yeah. Today, I will have a first talk talking about how can we adjust what's called digital health care in this area, yeah. And then the second speaker, yeah, we'll invite Dr. He Zixing. She is from Shinshika Academica, yeah, and she is well known about we call the biobank and how to protect we call the personal data, and this is very important for us because I want to share the big data. And so far, many people, they try to protect the human right. So they always ask, we have to get the permission from the people. Yeah. So we ask Dr. Hong to give us a talk. And the third speaker will come from the George Washington University, Professor Liu. Yeah. She will talk about something about we call the antibiotic resistance. Yeah. I think this is very important for the medical field recently. Yeah. And the fourth speaker, we invite also my colleague, Joyce Wang. Yeah. She's talking about what we call the virtual national health insurance card. This is quite important because in the past we just used the solid national health insurance card. But when we try to treat the patient, they maybe they are in some high mountain area, or they are in, we call the offshore area. In that situation, it's not easy to carry some machine. Yeah. So we just use the virtual health card. I think today, all the information from our national health insurance will be very important, and we are happy to share our information with all of you. Thank you.
Thank you so much. And Director General Lee, would you please continue with your first keynote talk?
Okay. For me, yeah, I want to have a talk about the big data application, yeah, for disease prevention, yeah. And as I just mentioned, in the past, I'm a surgeon, yeah. So generally, when we try to treat the patient, we always say, this is my personal experience, but so far, that means the situation is quite different. We try to use the big data. And in Taiwan, the national health insurance already 26 years, yeah. In the past, we just have some claim of the data and to get, the reimbursement, yeah. But so far, in this area, yeah, we try to use this information to do more study, yeah. So I just want to share our information with all the people here and some audience online. Yeah, I think it is very important in Taiwan. Yeah, the NHI system, we are just a single payer system. This is quite different from the Western country. It is also from, we say, the commercial insurance. Yeah, but in Taiwan, we use the single payer system and run by our government. Yeah, but sometimes the premium, yeah, we say the premium we got from the people or from some employee or from our government. So in that way, we try to use the growth budget to control the expenditure. And in the Taiwan, some medical professionals, they are not very comfortable about our growth budget. They think we just fix how much money we want to spend. This is not fair for them, yeah. And in Taiwan, yeah, generally for the government, the people always not very satisfied to our the running process. Yeah, but for our NHI system, we can see more than 90% of the people, they are very satisfied to what we have done. But frankly speaking, for some medical professionals, especially medical doctors, only 30% they are satisfied with what we have done. Yeah. So we try to do our best to let the medical professionals, they are happy. They have a very happy environment to work. But for people, we wish they can get a good health system. Yeah. So when we are talking about the big data, we say, for this big data, what we can do? We should management how this data. I think this is very important. Today, I want to share with you all of you about the information we have done. Yeah. And the second, recently, since we have the IT, we use the AI program, yeah, to let this data have some clinical application. This is very important. And the third, since I mentioned that for some of this data, for the people, they protect the human right. They always, they say, we don't get the permission from the people. So later, Dr. Ho, we're talking about how can we pay attention to the privacy and the security protection. Yeah. So for the 26 years, yeah, we collect all the information. This is, as I mentioned, this is quite different from Western countries. Yeah. In that way, we see for the for this area, we know many drugs, they are very efficient to treat the rare disease, to treat the cancer, or Yeah, so the price is always very expensive. So we spend that money, yeah, in the drug. And another way is that, you know, for some patients, they are in this era, yeah, we try to give them some examination. For example, CT scan or MRI. They are all very expensive. So this price is very expensive. So as I mentioned, that we should have some management tool. Since we know the price, the payment that is increasing in the drug and the examination. So we know how to control the payment. This is very important for us, yeah. So since all the data, I mean, we get in our NHI, yeah, we can see we have the surgery record, examination record, and the dental service or the examination result, and the immunization record. For all this information we got, and we upload to the medical cloud, I think this is very important. Why we want to do that? Because in Taiwan, generally, we don't have the referral system to give the people medical care, yeah. But you know, if you have done this kind of examination in the medical center, however, when you go to the clinic, you want to see your family doctor, yeah. If they can get the information from the medical cloud, I think it is good for the people here, yeah. So we try to build a good medical cloud system, yeah. Generally, you know, if it's necessary to have the effective tool to do good work, we say in Chinese, yeah, we say 工欲善其事，必先利其器. I think this is very important. In the beginning, yeah, you know, in the past, we just use the ADSL system. So, in that way, for example, some CT scan or MRI image, it's very difficult to upload, and for the clinician, when they use their computer, it's very difficult to download this kind of image. So we spend our time to wait for this kind of image. In that way, the clinician will be very, very happy. So when we use the optic fiber, yeah, in that way, it's very efficient. So in that way, it's easy for us to make success of the referral system, yeah. As we know that generally for the people, if they have any discomfortable, for example, maybe you have you have done the endoscope for the stomach, or you do the endoscope for the colon, yeah, it's not very comfortable for the people, yeah. So when you are in this hospital, you have done this kind of examination, you go to another hospital, it's better not to repeat this kind of examination. You can just see the result, it's fine. And for the CT scan or MRI, we know CT scan also have some radiation dose, yeah, especially in Taiwan. Recently, we are scared about the radiation dose, which it means the nuclear food from the Japan, yeah. But you know, in general, yeah, if you have done a lot of the CT scan, you got many radiation dose, yeah. So which the people here, they don't need to repeat it to do this kind of examination, yeah. So when we can upload this information in the medical cloud, it's easy for all the people to get the same data, yeah. So we say just in Taiwan, yeah, now we just in our medical cloud, we have the big data, just we claim data. It means that you go to the hospital and how much we pay for this condition, yeah. We also have the laboratory test. We also image report or image and the data, yeah. I think it's all in our, we call the NHI big data, yeah. So last year, I mean, during the January, you know, the COVID-19 got a very serious problem for us, for our society. In that way, Taiwan, yeah, since we have already very good network, so we have the TOCC, you know, it means travel information and occupation and contact and cluster history, yeah. So for all the medical providers, even you are in the hospital or you are in the clinics, yeah, or the medical staff, they can know, oh, where do you come from? Maybe you come from some area which is very dangerous. So the clinician will say, oh, you remember your symptom, not only the URI symptom or only the GI disturbance. Maybe it is possible it's just a symptom of the COVID-19. So in that way, in Taiwan, why we protect the people very well, just in this situation, yeah. Since this is a big data, generally in Taiwan, yeah, in the beginning, we are not have so many tools to do what we call the PCR study to detect the COVID-19 infection. We use the X-ray. But you know, since Taiwan is a single payer system, so we can collect many chest X-ray, yeah. So in that way, we can let the physician to learn which this X-ray is comparable to the COVID-19. I think it's very important, yeah. So this is very important for us to use the we call the AI model to do this kind of study. And we know the FL model, yeah, is also, we join the program, yeah. So we also get a very good information in this part, yeah. Since in Taiwan, yeah, you know, in the beginning, we don't have enough mask, facial mask, we don't enough. But you know, for so many people, how can we get them to have a very fair distribution? This is very important. So, but however, we have NHI card. So in that way, we can distribute the face mask very evenly, yeah. So in that way, is our colleague, I mean, they try to build this system within a very short time, yeah. So in Taiwan, yeah, we can find the most people, they can have their face mask. And during that time, we found that the influenza-like illness obviously decreased a lot. So this is very important for public health protection, yeah. And we know in Taiwan, since as I mean, we are just a single payer system. So we can collect many information, yeah. And in the beginning, we know for some patient, they got the cancer. Maybe we just treat them with the chemotherapy or target therapy. But recently, immuno-oncology therapy is also very important, yeah. So in that way, yeah, we know this is the price is just 3 times compared to the target therapy. However, in Taiwan, yeah, we have enough information. We know the real world data. It means the real NHI data. We see, okay, this is not necessary for us to treat this kind of patient. So for the patient with the hepatocellular carcinoma or the gastric cancer, we found that it's not better than the traditional target therapy. So we don't want to pay 3 times price, yeah. So last year during April, we stopped to pay for this kind of treatment, yeah. And then during the end of April, in the United States, the FDA also found that the conclusion, they say it's not necessary to treat the hepatocellular carcinoma or gastric cancer to use the immuno-oncology therapy. So I think in Taiwan, yeah, we are the big data, we can do more and good to our people. And recently we found the patient, if they are got the hepatocellular carcinoma, yeah, and then they also have the hepatitis C, in the beginning we think maybe it's not necessary to treat this kind of patient, yeah. But however, in our data we can find even the patient all belong to the hepatocellular carcinoma, but if we treat them hepatitis C, the people they are being treated, and compared to the patient, they are not treated, and the survival rate is quite different. P-value is very significant, yeah. So we submitted this paper to the good journal, yeah. Last year, I was invited to go to, 2 years ago, I was invited to the Columbia University to have a debate with the people there, yeah. You know, in Western country, they always use the commercial insurance to cover the health care. But in Taiwan, we are just a single payer system, yeah. So I believe, yeah, single payer system, if it is very efficient and good government, yeah, I think it's good for people. And I think it is very important. So since I was in this job already 5 years, I was proud to have this opportunity to handle our national health insurance. Yeah, I think we can try to let the Taiwan people get the best life, yeah. And we are lucky, yeah, because yesterday, 2 days ago, we just get a letter from Springer, yeah, because we try to let I mean, the strategy we had done in Taiwan, the digital health care in Taiwan, and this is the innovation of national health insurance, yeah, and they give us a letter. They approved to publish our paper, to our book. Yeah, I think it's proud for us NHI group. Yeah, I think this is what I want to share with all you. Yeah, because in the future, if any people here or in the audience in online, if you are interested to contact with Taiwan NHI, we are very happy to do that. Yeah. finally, I think this is Taipei 101. Yeah, I think all the people, it's very beautiful here. Yeah, so I think in the future, any party, if you have opportunity to come to Taiwan, you can contact with RNHI. Yeah, we are happy to host you. Thank you. Thank you very much.
Thank you very much to Dr. Bo-Zhang Lee, Director General of National Health Insurance Administration, for the very informative talk.
Okay, now we move to the second topic. Yeah. Okay, now we invite Dr. Ho. Yeah. Dr. Ho is very smart. Yeah. I think she is very smart. She is graduate from the law school of the National Taiwan University. Yeah. She also got a master's degree in the Columbia University and the Stanford University. Yeah. And finally, he go to the UK to get the PhD degree over there. Yeah. In the UK, the university is very difficult for me to pronounce. Later, you can introduce yourself. Yeah. And today, she want to have a talk about what we call the personal protection. Yeah. I think it's very important for us to know how can we, during this digital healthcare system. Yeah. How can we meet them? Yeah. Thank you. Okay, please, you're welcome.
Let's welcome Dr. Zhixing He, Associate Research Fellow, Institute of European and American Studies, Academia Sinica, Taiwan. Please.
Yeah, thank you very much. Thank you very much for your kind introduction, Director Lee. Ladies and gentlemen, good afternoon. It's really my great honor to be here. And as Director Lee just mentioned, in my session, I'll focus more on the legal discussion on the secondary use of NHI, National Health Insurance data. I think this turns to be a more and more important topic because we talk lots about how do we use the NHI data for the big data application, but we didn't really pay much or equivalent attention to the data protection part. I think it's quite important for us to discuss. So when we talk about the big data application, we see the National Health Insurance big data will require integrate different databases. But we know that different database, it has its own original data collection purpose, right? So for example, the claim data, the main purpose for administrative purpose for the premium auditing. And for the image report, for medical image data, we use this important data for diagnosis and treatment purpose. And now we integrate all this data to turn into a big data application. Now we want to open this big data to third party to access. So for third party to access for academic or commercial use purpose, now we change our original purpose for collection. So in law, we give a definition about the secondary use because so long as we collect data and now we want to use that outside of its primary collection purpose, now we need to have a legal basis for the secondary processing, data processing. So usually, this legal basis can be satisfied with people's consent. It's the most easy way. But in the National Health Insurance database, it's quite different. Because get consent is actually quite costly. The data already being uploaded into the central database. So if we want to use that for the secondary use with different purpose and we get the reconsent, it's probably costs too much. So nowadays, another legitimate or lawful way is that we focus more on the data itself. We only focus on how do we make the data be de-identified. And we felt like so long as the data be de-identified, and so long as we have quite legitimate purpose, legitimate interest, like high popular interest for open the data, and now we can satisfy the legal basis. Yeah. But this kind of discussion is actually quite difficult nowadays in practice. And one reason is that we, in reality, we do not really have a clear standard about how can we deal with the data. At which point we can be satisfied to say this data is quite safe because this data is completely identified. And the other one is that the limitation of the identification itself. In the big data era, So for example, if we only deal with one database, it's quite easy. But we are not quite sure how many data still remaining outside of this particular database that can help us be linked back to find out the particular individual. So based on this difficult, now we know the great challenge about the open data for the secondary use of national health insurance data is that we focus too much on data security itself. We focus too much and talk only about the identification. But at the same time, it seems that we forget the issue is more about data subjects exploitation. Do we really have opportunity to know whether the particular individual, whether they will be happy to share their data and to whom to access? So here, the main message is that the data security itself cannot be equivalent to privacy protection. So if we look at other jurisdictions, for example, the European, the EU, the General Data Protection Regulation, the EU GDPR, it was released in 2018. And according to the rule, it says quite clearly, if we just make the data be de-identified, but we still keep some additional information that allow us to be able to keep attribute to a particular individual, and this kind of technique we call pseudonymize. So we cannot treat the pseudonymized data as anonymized data. So long as the data still be able to be linked or be matched to find a particular individual, this data, pseudonymized data, is still personal data. And under the EU rule, it still need to be protected under the data protection law. But in Taiwan, it's quite, unfortunately, it's quite difficult. So in practice, many people will just treat the pseudonymized data as anonymized data. I think it turns to be a quite difficult situation to deal with. So on the other part is that when we talk about the legitimate interest, we talk about popular interest. It's quite true, the open data has quite good popular interest, but we didn't really have opportunity to distinguish a different layer or put the popular interest into different category. For example, during the pandemic period, we can see the public interest is very, very high. So now we have a substantial public interest. But if we talk about the general academic research, or if we want to talk about how can we open data for the commercial use, then the public interest might be decreased a little bit. It could be the general public interest or even low public interest. So different category of public interest will actually have a different kind of consent mechanism to match up. So for example, at a very important time and space, the pandemic prevention, we call it substantial public interest. And now it's very important to protect the public good. So now we can collect people's data, and even without asking their consent, right? Or even do not allow them to choose to opt out. But at a certain circumstance, for example, the commercial use, now the public interest decreased a little bit. So now we cannot really treat this kind of open data policy as the same as we open the very important substantial public interest data for the third party to use. So now at this situation, we probably need to ask data subject, and we use the opt-in method to ask them whether they will be happy their data to be used. So it's quite important to distinguish different layer and different category of public interest, and it comply with different setup of the consent mechanism, whether here we choose opt-in mechanism or we would prefer to use opt-out. So here in July this year, the National Health Insurance Administration decided to have this, I think it's a very, very good trial. We used the My Health Bank, the digital platform, to do a trial and do a survey as well. We want to ask people, we want to ask people whether they will really be happy to share their data, either for the academic research or for the commercial use. And why we decide to choose the My Health Bank as a digital platform is that as the COVID-19, and now we almost reach, I think, if my data is correct, now over 7 million people are enrolled into the My Health Bank, and it's equivalent to 1/3 of the total population in Taiwan. So it's a quite good platform to get people's opinion. So I think the trial was actually ended around the middle of October, but we analyzed data until a few days ago. So according to the data, we can see, here we can see, we asked the two main questions. And in the long run, we also want to make the question be even finer. So the first question we asked that, for example, would you be willing to provide your personal data for academic research if in the future you have this option to decide and like the data will have been de-identified? And this is the final wording. So from July, from beginning of this survey started, we actually revised a little bit about the wording because originally we used the double negative in the one sentence. So we thought it's probably a little bit ambiguous for readers to understand whether to choose or not. So later on, we just used the affirmative sentence and for people to decide. And another question is about the commercial use. And here we ask them whether they will be happy, they will be willing to share their commercial use, their data for the commercial use. And now we can see the result is that here is the final, the aggregated result for both of the original wording and the revised wording one. If we focus only on the revised wording, and we can see the people who decided to continue to support academic research is actually quite high. We have around 93%. But if we look at the commercial use, then the supporting rate decreased a little bit. Now we have 83. And in general, in terms of talking about the academic research, we still have around 82% people will be willing to support. So people will be willing to have their data to keep, remain at the database and decide not to opt out. So people, if we just look at the Taiwan's data, we'll probably quite happy and be confident to say, okay, we now have 82% people who will be willing to stay at the database. But if we compare with data from the other jurisdictions, for example, in the UK, we can see the opt-out rate in the UK is much, much lower. So we say the opt-out rate, if it can show the people's true opinion, and if this data have kind of representative, then actually the opt-out rate in Taiwan will be quite high. And this kind of opt-out rate, high opt-out rate, will have certain social costing. For example, it will directly infringe the data integrity. It's always a trade-off between the privacy and data utility. So if we want to have to respect people's autonomy to decide, at the same time, we probably need to compromise a little bit about data integrity. And the other side is that we are not quite sure about this particular person who decided to opt out. Usually, according to the data from other countries, usually they're probably the particular group who need access to healthcare the most. So they probably be the rare disease group or minority group. We're not quite sure about in Taiwan, but it shows that the representative could be an issue. So at the concluding remarks, say that it's still quite important to respect both. Both of the value need to be treated at the same time. So we need to respect individual autonomy, their self-determination to decide how to use their data and who can access their data for commercial use or for academic use. At the same time, we also want to facilitate data use. So both of these values need to be respected at the same time. And the other side is that we need to have another mindset to see the de-identification. We need to look more on the data governance mechanism. For example, pay more attention on the privacy impact assessment. And here, the privacy impact assessment cannot really be reduced as a data security. It's much more. It's a contextual analysis, and we need to consider the data subjects' expectation, whether particular people they will be happy their data to be used, or whether they happily saw their data will have been used in that way. So we need to move from the narrow definition of confidentiality to a broader definition about the data control for people to decide. And the most important thing is that we need to have more public engagement to make all these data sharing policy to be transparent enough. So long as we have more transparent policy with the efforts of public engagement, I think in the long run, it actually can help us to rebuild the social trust about sharing of national health insurance data. So my message in the end is that we probably cannot really rely on the de-identification itself. De-identification has its limitation, but privacy protection is much bigger concept. So I look forward to more discussion with you all. Thank you so much for your attention.
And now we invite Professor Liu. Professor Liu, she's working in the George Washington University, yeah, and she will talk about the antibiotic resistance. And we are very appreciate Professor Liu. She's very kind. And 2 days ago, she just sent us, the video, yeah, and to speak in Chinese, yeah. Then we ask her to translate back to English, yeah. So actually, she speaks English better than Chinese, yeah. But she tried to let us know more, yeah. So we appreciate it a lot, yeah. And this year, yeah, I think she got the president mentor from the George Washington University. And I think 2 years ago, I met her in George Washington University. She's really very kind and very smart, and she treated Taiwan people very well. Yeah, let's welcome Professor Liu.
Hi everyone, I'm Cindy Liu. I'm a professor at the George Washington University here in Washington, D.C. I want to thank the organizers for the opportunity to come and share my perspective on how Taiwan can be a leader in the fight against antimicrobial resistance. Before I start, though, I want to take a minute and explain what is antimicrobial resistance. I'm going to do that using some cartoons. So this is my bacterium, which through natural mutations, a bacterium can gain natural resistance against antimicrobials. And this can happen when bacteria grow and replicate. So I'm using a lightning bolt here to represent drug-resistant bacteria with natural resistance. So in nature, your drug-resistant bacterium lives among a large susceptible bacterial population. And when we use antibiotics, it doesn't matter where or why. It kills off the susceptible population, and it leaves the resistant bacteria to grow, proliferate, thereby creating the problem of antimicrobial resistance. When we think about why antimicrobials are used, we often think about human medicine. But actually, we use a lot of antimicrobials in raising animals. And this means that it's selecting for drug-resistant bacteria in the gut of these animals. And we also know that many of these animals are actually made into food that we eat. So the drug-resistant bacteria can contaminate the food and be transmitted to consumers, colonizing their gut, which then can be transmitted to other individuals or cause drug-resistant infections in the consumers later. So antimicrobial resistance is a One Health problem. And this is because when we use antimicrobials, not only in humans, but also when we use them in animals or in growing animals or plants, it's worsens the issue of antimicrobial resistance. In addition, not only can humans be a source of antimicrobial resistant pathogens, animals and plants and even the environment can all be the sources of drug-resistant pathogens. And this means that drug resistance is really exacerbated by environmental control issues, such as how animal waste or wastewater are handled, or the quality of our drinking water infrastructure. All these are connected. So the United Nations recognize antimicrobial resistance to be one of the greatest public health crises that we face today. It is called a silent pandemic. As we continue to deal with the issue of COVID-19, if we want to prepare for the next pandemic, we must address the drivers of antimicrobial resistance. Antimicrobial resistance really requires our urgent attention because drug-resistant infections undermine progress we have made in modern medicine. And this is not just about treating infectious diseases. Without effective antibiotics, antimicrobials, we cannot have safe surgeries. We cannot have organ transplants. We cannot have effective cancer treatment. And things like giving birth would be really dangerous. In addition, our youngest and our oldest would be in huge danger, at greater risk of developing drug-resistant infections. So antimicrobial resistance especially requires urgent attention here in Taiwan, and it's because it's already here and it's an issue. So in humans, we know that approximately 60%, for example, 60% of the healthcare-associated Staphylococcus aureus infections are resistant to methicillin, which means they're caused by methicillin-resistant Staph aureus or MRSA or MRSA. We also know, actually, here in Taiwan that nearly all the poultry and most pork products are contaminated with multi-drug resistant E. coli. Taiwan has been taking, actually, I want to acknowledge Taiwan has been taking great action against antimicrobial resistance already. What I know is that since 2017, there has been collaborations to promote antimicrobial stewardship among the Taiwan CDC, together with the Bureau of Animal and Plant Health Inspection and Quarantine, as well as the Ministry of Science and Technology and Academia Sinica. And Taiwan has also been making progress in drafting a national action plan on antimicrobial resistance. All this is great progress. But what I'm here to make a case for today is to tell you that Taiwan is uniquely positioned to be a world leader in the fight against antimicrobial resistance, against drug-resistant infections. And this is true for many reasons, but two big reasons I want to bring up today. First is the fact that we have the best national healthcare system in the world with an excellent data infrastructure. And secondly, it is the Taiwan CDC, which has excellent skills and leadership in large public health action, as it has demonstrated in the excellent Taiwan COVID-19 response. So this means that Taiwan has the unique opportunity to take the first step, what I call a big data, a One Health big data, to leverage the unique capabilities of Taiwan to make progress in this way. And specifically, Taiwan can make huge progress using big data on two specific items. First is how antimicrobials are used in Taiwan. And second is to capture fully nationally the reservoirs and infections caused by drug-resistant pathogens. So Taiwan has the unique opportunity to connect its National Health Insurance Program database with the Taiwan CDC, connect that to the Council of Agriculture, EPA, and Taiwan FDA to create a national big data on One Health. This is an opportunity that very few countries in the world have, and it can make a huge difference. From what we learned so far in the COVID-19 pandemic, we understand the importance of One Health. We understand the importance of prevention and early detection. So it is hypothesized that SARS-CoV-2, which is the virus that caused COVID-19, comes from animals, which then infected humans, and it is what's called a zoonotic disease. In terms of drug-resistant infections, we also worry about zoonotic disease. Even though we know drug-resistant pathogens are actually transmitted from animals to humans quite frequently. But what we especially worry about is what is called a pan-resistant pathogen, a pathogen that is resistant to all the antimicrobials that we have. So first I should point out that to minimize the risk of such a catastrophic event happening, improving how we use antimicrobials is really a critical step. So that must be addressed. But when we have One Health big data, there are other things that we can also do that's important. And so first, we can use the national big data to rapidly detect any new zoonoses of drug-resistant and potentially pan-resistant pathogens and infections. And this can help us to prevent an early and use this for early detection and prevent the worst case scenario. It's really critical. Second is that the One Health big data can also allow Taiwan to measure the impact of any of the interventions it puts in place. And lastly, I definitely need to mention that when you have such a robust One Health big data infrastructure, it can be used for any other One Health challenges, not only antimicrobial resistance. And what I'm proposing is that it's not only about creating a One Health big data, it is about creating the best that is possible. And what's really critical in accomplishing that is to collect data that is actionable. And actionable data has to have a few characteristics, including that it must be accurate, that it has to be rapid, and it must be complete, with enough details on the antimicrobial use and the pathogens to be able to take action to measure the problems specifically and to be able to assess the effectiveness of the interventions. And regarding what I had mentioned before about the two big items that the One Health big data can capture, Taiwan has the opportunity to collect how antimicrobials are used, the type, the quantity, who used it, where and when and why. And this data can be collected from all the human sources, including medical clinics and dental clinics, as well as agricultural uses in animals and agricultural productions. Taiwan also has the opportunity to collect national data on drug-resistant pathogens. And Taiwan can do this not only by collecting all the lab results that are available from hospitals and clinics, it also has the ability to build a robust collection of the actual pathogen isolates for laboratory analysis and sequencing. And Taiwan has the unique opportunity to institute robust national sampling from not only food, but also healthy animals. And this type of data can be then transmitted to a centralized organization or team, such as the centralized team Taiwan has developed to deal with COVID-19. When such One Health big data is available, that also opens up the opportunity to develop solutions that can be market-based. So here in the United States, we have this labels that can be applied to meat products. And this type of, and by having more data, big data here in Taiwan, this will allow Taiwan to offer its consumers more choices. And so in the United States, what we have are these conventionally raised animals all the way to what's called raised without antibiotics. And the American meat products have these special labels. And my center, the Antibiotic Resistance Action Center here at George Washington University, we work on these market-driven solutions. And we specifically run a label, what's called Certified Responsible Antibiotic Use. And so this supports responsibly raised meat products. So what this means is that having this type of a solution will allow our farmers to still use antibiotics to treat sick animals, and also allow consumers to, choose what they want to purchase products that are raised responsibly. But I know that even though the meat labeling can be a solution for Taiwan, but I know Taiwan has different ways of selling meat products, different types of markets. And ever since I was little, I've loved the traditional markets of Taiwan. So it is possible that perhaps Taiwan could focus on a national solution that looks to develop a national minimum threshold based on the drug-resistant and antimicrobial use data from the country. And this will ensure that it does not matter where the meat product is being purchased, any type of markets, that the consumers have the minimum protection. So I'm a huge fan of Taiwan, and I really believe that Taiwan can become a success story in using One Health big data to protect its citizens. And from what we know through the COVID-19 pandemic is that this is much more about protecting the citizens' health. If we're successful in preventing the next pandemic, we can protect also the health of Taiwan's economy and Taiwan's society. I also want to stress that with this success, Taiwan can become a leader in this issue in Asia and really worldwide. So I just want to thank the organizers again for the opportunity to share my perspective. And I am actually from Taiwan, Kaohsiung originally, so it's especially great to be here. And if anyone has any questions or comments, please do feel free to reach out to me here at my email. Thank you again.
Okay, thank you, Professor Liu. Yeah. And our last speaker is Joyce Wong. Yeah, Joyce Wong is working in the NHI. Yeah, and I think she's very smart. She works a lot in the public health and some medical management. Yeah, And previously, she ever stayed at the United States in stand for our Ministry of Health and Welfare. Yeah. And today, she wants to talk about the virtual health NHI card. I think this is quite new, yeah, and very useful for our medical care in the Taiwan national health system. Yeah. Let's invite, welcome Joyce to have a talk, please.
Thank you, Shu Zhang, and good afternoon, everyone. It's my great honor to share how the virtual NHI cards facilitate easy access to medical care. Let's start from a little story. The first NHI card is a paper card, but NHIA completely replaced the paper card with the IC card in 2004. In 2007, the Executive Yuan decided to develop the new digital ID program. So we put the second generation NHI card renewal plan aside. And we hold 3 collaborative meetings to promote the NHI card reforms. We listen to diverse opinions and come out with a people-oriented design thinking. That's a new idea about the virtual NHI card. It's under the big project of the smart government, which supports the national digital transformation. The initial planning of this card is to integrate the NHI online services, medical behavior, and more value-added application. We conducted this pilot program from 2019 under 3 principles. The first is retain the current entity system and develop virtual NHI card system step by step. It's a pilot program, not mandatory for now. The third is we focus on medical use and will not include other add-on functions yet. The first year we developed the system, we collect experience and obstacles of users, and we evaluate the information security. The second year, we keep strengthening the system, establish the security signature mechanism. A new idea is combining the NHI Express app and provide SDK. And we try to introduce the NHI card on multi-medical fields on different situations, such as hospitals, clinics, pharmacies, rehab centers, and home care. There are over 2,600 cases we tried, and include the elder, the disabled, and vision impaired patient. We analyze the cost effectiveness, compare the resources we have to input, and make strategies for future expansion. This year, we implemented mainly focus on 3 major trials on typical medical fields. The first is the home-based medical care. The goal is to alleviate the heavy burden of facilities on doctors and nurses and reduce the inconvenience of family members. The second is the teleconsultation for rural areas. Doctors on both sides can reach the information of patients by scanning the QR code and do claiming data. And the third is the telemedicine for the quarantined and more people can get medical care by using virtual card without actually going to the hospital to complete the process. This is the structure of the pilot program. There are 3 interesting functions. The first is for rural area, we add the offline digital signature. For system, we integrate different medical information system. The third, for public, we established the online application and the authorization mechanism. The questionnaire shows that the satisfaction rate is pretty high, no matter from the process of application, authorization, and the privacy protection, and willing to recommend. There are already over 36,000 people have their own virtual NHI card, and there are over 770 medical institutions willing to participate in this project. We connected the 6 divisions of NHIA and the participating medical institutions through VPN and the weekly email to resolve the related issues for them in time. What's the difference between physical and virtual card? From the preloaded data, we can see that the virtual card actually has limited or less preloaded data. Less data means higher security. And you can see that there is low cost, no charge for the QR code. And we can put larger data set by uploading to the MediCloud. So reading space is faster. So it's more convenient or efficient. We bind the NHI card to the mobile phone so people can show the QR code for registration, consultation, and examination. So the contactless or zero contact medical treatment mode is possible, and we can reduce the risk of infection. People's rights and interest in medical treatment will not be affected because both the virtual and physical card are in use simultaneously. So you can see that that's 5 easy steps. Enter the card system, complete the identity verification, agree to participate, and the most important is upload your most beautiful photo and get a virtual NHI card. And we posted lots of details about the virtual card pilot project. And we let people know how to authorize other family members use the virtual card and reduce the inconvenience of passing physical cards between caregivers. In summary, you can see the video.
Okay.
Sound? Something happened in the soundtrack.
还是可以帮我们再重播一下，然后确认都有声音，谢谢。I will try to roll the video again.
所以10分钟可以时效中断一下吗？老师。Okay. Okay, that's okay. So I quote Dr. Po Chang Lee, our Director General, said, "The virtual NHI card is actually a great breakthrough in Taiwan's medical history." From 33 medical institutions, now we have over 770 medical institutions in total around the country, include 14 medical centers and 30 regional hospitals. And we keep collecting opinions of stakeholders. The first year, you can see that over 50% of people dislike the installation process. And the second year, we try to introduce the new IT technology. So the condition is totally changed. 86% of people feel that the process is convenient. And the 87% general public would like to have a virtual card. And more than 90% home care patients look forward to have a virtual card. Considering that need, this year, we established the authorization function to help patients authorize the caregivers to use the card. So facing the post-COVID-19 era, implement the national epidemic prevention policy is very important. As everyone knows, no contact or less contact means less risk of infection. Improve the convenience of medical care means improve the accessibility or even the accuracy of medical care. So the virtual card actually can play a big role in assisting in epidemic prevention. Next year, we will try to fully implement it in 3 fields and keep expanding the promotion. As physical card, we believe that the virtual card is a useful tool for ID verification and will become a powerful platform for public services. So the virtual card pilot program is actually a teamwork. I'd like to acknowledge all the team members and participating hospitals and our partners. Special thanks to Sun Haochun, Deputy Director of IT Division. He's quite a genius, like Minister Andrew Tang and Lin Chunmei Zuzhang for your great efforts. That's all I have today. Thank you very much.
Thank you, Dr. Wang. Would you please just join us on the stage for the panel discussion? 我们是直接请组长在台上就加入我们接下来的综合讨论。And we're going to have a panel discussion right now. And let's welcome our moderator, Director General Lee, and also our speakers. Dr. Ho, please take a seat on the stage. We'll proceed to the panel. 好，那就请我们的这个署长以及我们刚才几位讲者呢，就到台上就坐。接下来是我们综合讨论的时间。哦，刚才那个影片好了，是不是？那我们再播一下好不好？可能透过影片我们会看得更清楚。The video is ready, so we're going to have a look first, and then we'll have the panel. All right? 好，请播。
疫情爆发，不少民众减少去医院次数，透过健保署推出的视讯诊疗，慢性病患看病拿药更方便。科技在升级，虚拟健保卡正式上线，只要下载健保快易通，完成身份验证，同意参加示范计划，照片上传就能取得虚拟健保卡。
让医疗院所透过3卡认证，可以看我们的病人的资料。那我们最近发现很多医疗院所也都主动加入了用虚拟健保卡做看病的一个过程，所以我想这是在台湾的医疗史上也是算是一个很大的一个突破。
科技进步，健保卡就像信用卡，绑定手机，未来 QR code 挂号、看诊、检查零接触。
Okay, thank you once again, Dr. Wang, and over to Dr. Lee.
Well, now we have finished our talk, and now we move to the discussion. Yeah. So, any question or comment from the audience? Okay, I have to raise the first question. Yeah, this is from the audience, from the the YouTuber. Yeah, he said the function of the NHI card has gradually exceeded the health field, such as the五倍券quintuple stimulus vouchers, but the public doesn't actually authorize the use of an NHI card in this way. I would like to ask what the boundary is and how to ensure the privacy and the safety of the use of NHI card outside health field. I think this is generally, I think basically this is just the government policy, how to use the NHA card to promote the government policy. Yeah, I think basically we don't think it is illegal. Yeah, it is maybe just for public interest. But I would like to ask Dr. Ho to give us a comment. Yeah, please.
Thank you very much. I think the question raised a quite fair point, to be honest. So the main issue is that if we collect the health data, and we actually have the primary collection purpose. So now if we want to use that for a different purpose, we need to have some legal basis for that. And probably, as the directly just mentioned, is during the COVID pandemic. So we need to find a proper, appropriate mechanism for people to access, to use that to purchase the vouchers or something like that. But I think in the long run, it probably requires some more social discussion and to make the public understand whether this way to use the NHI card is really the best way, or whether we can find other opportunity, or whether we can really satisfy the principle of necessity and not to use the card, but find other ways to do and achieve the same goals. I think it would be a more proper way in the future. But I think at this point, we probably would just see it still depends on the people's, the whole society, whether people will be willing to accept this way to use the card or not. If for those people who concern more about data protection and privacy, I think for those people who have this concern, they would just prefer not to use the card in that particular way. Thank you. I think it's a very good question.
Okay, thank you. Yeah. So we know the NHA card now is more popular than any other card. Yeah. So when you go outside the home, yeah, maybe it's necessary for you to carry your NHA card. But you know, this time since we have many businesses just contact with the NHA card, so some of the public we challenge whether NHA card is can be used in that way. Yeah. So later, yeah. Any other people to have different comment?
Yeah, any questions? 用中文或英文提问都可以哦。
Shira, do you have any comment?
I have a question. When will you expect to roll out the NHI virtual card? And will it link to the vaccine passport in the future?
Joyce, please.
Thank you for your question. As I talk in this section, the virtual card is actually a product of brainstorming. But after broad discussion, we decided to implement the pilot program under 3 principles. One of the principles is focusing on medical use. So for now, we don't have such plan to integrate or expand our usage to the passport.
Yeah, I want to have a more comment. Yeah, basically, we know the virtual NHI card is just a supplementary to our solid NHI card. Frankly speaking, if you are in the medical practice, it's better, to treat the patient face-to-face is better, yeah. But so far, the telemedicine is also very popular and very hard in the modern medicine. But for us, we do believe the telemedicine is can be used, in the rural area or in high mountain or in offshore. Because in Taiwan, most of the medical information, we just call the MediCloud. We need 3 cards together, or the patient NHI card and the clinical card, and the doctor's card. Yeah. So we have these 3 cards together. Then they are allowed to see the MediCloud. So this is very important. Yeah. So in the past, if we don't have we want to see the MediCloud, all the doctors go to the high mountain. Yeah, they have to carry some equipment. So it's very heavy, not very very comfortable. Yeah, so we try to build we call the energized virtual card. In that way, you don't need to carry so much machine to the high mountain. Yeah, so we think that it is just one supplementary, because in Taiwan all payments are paid by our NHI. Yeah, so sometimes for some doctors maybe they thought that it's easy to use telemedicine to treat the patient and more easier. Yeah, but nobody know whether they have already done this practice. Yeah, so I think we just doing the virtual medical card step by step. Okay. Yeah. Sheila, do you prepare your question? Okay, please. Sheila is from our NHI.
NHI app is very popular right now in Taiwan, and we also include the NHI virtual IC card in our app. And what's the development? Your expect to use this app to do more things? I want to ask Dr. Lee. Do you know my question? I want to know what do you expect? What's your expectation to use the NHI app in the future?
I think. So this is. I think that answer should be from Joyce. You're giving the response.
Let me start first because it's a technical issue. As you know, if you care about our NHI app, do you aware of that we add on many new functions recently for fight against the epidemic? Anyone can share your experience, like the vaccination history, like the PCR examination test. And we also have My Health Bank, new edition. So this is all these new stuff actually come from the idea of Dr. Lee. I don't know why he has so many ideas, because every day he will come up a new idea. So what's the expectation? Good question. Maybe the expectation is, as his inferior, I think maybe he expects that 23 million people in Taiwan can get used to this app. And by using these apps, empower themselves to control their health. And they can do more if they have the app. And if they control the data, like the medical visit data and more data, they can have more power to do some health management. I don't know if I am right or not. So Dr. Lee, I think everyone wants to know your expectation.
Yeah, you know, I'm already to be a surgeon for 40 years. Yeah, since I was in this job, right, I was thinking this is a good opportunity for me to rebuild our NHI system. Yeah. In the past, yeah, maybe we are just, the government official, so we just are doing something step by step. But so far, I do, because I have many friends, yeah, they are all medical professionals, yeah, so what they have some complaint, I can hear from them, yeah. So I wish all what we have done is really good for the medical environment, yeah. So this is sometimes I ask my colleagues, yeah, to pay attention to the efficiency of our system, yeah. So you say the NHI app, yeah. I think it is really, we have done it very well. In the past, in the beginning, yeah, I have only around 30 million, yeah, 30 million, no. 300,000 people, they have used our, we call it our My Health Bank, yeah. But so far, I think almost 25 times more than that, yeah. So I think step by step, yeah, we can done it very well for Taiwan people, yeah. Okay, any question or comment? Sunu, do you have any question? You come from Taichung, yeah.
Here.
Wen. Where? Okay, please. Oh, yeah, there are two people over there. Yeah, please raise.
This is Lin Cai speaking. Thank you very much for all speakers sharing. It's appreciated that NHI is surveying Taiwan citizens' the awareness regarding processing NHI data for secondary use. And I'm wondering what's the next step on the basis of the result of survey. Thank you.
Yeah, thank you. Thank you very much for your question. I think the survey is definitely the preliminary step. So at the beginning, we want to know what the people think, what's the data in Taiwan, how's the people feeling about the secondary use of data. And in the long run, I think this survey can turn into a real product. And in the future, if we can really use the My Health app to do the electronic consent, and you could probably solve the issue. Now we always say the NHI database doesn't really have a legitimate basis. So I think it's a quite good way. But if we talk about the data, we see the opt-out rate is quite high. So there are still so much efforts we need to do. We need to have more public engagement to let people understand why it's quite important for them and to please them to stay, to share their data with us. Because in the long run, it will be help for the public good. So thank you.
I can have a more comment there. In the past, we don't care the human right to protect the personal data. So it means that in the past, when you are a surgeon, you want to do the operation for a patient, yeah. Maybe the patient just say, oh, I want to take some organ. But when you are doing the operation, you found a different organ have the disease. You also have to remove the organ, yeah. But now, it's not so easy, yeah. And Dr. Ho, she's also very experienced in the biobank, yeah. But in the past, when we collect the patient specimen or some blood, and in our we call our biobank, we just doing our research, but we don't care whether the patient agree or not. But so far it's different. We have to go back to ask our patient to sign the permission to let us use this, his human tissue, yeah. So we know this is very important to get a permission from the people, from the patient. But now we know in Taiwan we already have 26 years of the NHI big data. How can we do that? Yeah. So even Dr. Ho just talking about we have the high public interest or medium or low, yeah. But we know for our big data, I think it's really good for Taiwan government, Taiwan people. But we want to use this data, what we can do. So recently, in Taiwan now, we have we call the 健保快易通. It is also an app in our, our NHI system, yeah. So we have more than 1,300 million, 30 million people, they already have this app, yeah. So recently we asked Sheila to write to write something, yeah. And we wish to let all the people, they can push them to get to if it is possible for them to sign the permission for us to get the secondary use of this data. In the beginning, Dr. Ho just mentioned that we are using a survey in the My Health Bank. It's just a small number, but soon, yeah, we wish to get a more number to see what it is in our Taiwan people, yeah. If they really want to opt in or opt out, yeah, I think it's a challenge for us, yeah. But we try to do our best to let the people in Taiwan, they can know we NHI, we really, respect the human right in their personal data. That's all. Thank you. Xiong, do you have any question? Please, because you see the problem.
Actually, I follow the Dr. Po Chang Lee's question, and also NHIA's policy. But my question is for Dr. Ho. You have mentioned that the second use of health big data set of the National Health Insurance Program. So what's your opinion about whether we apply the opt-in or opt-out policy? Because they are different. Opt-in is more stricter because people are reluctant to join in. But for the opt-out, the critics maybe have their opinion. They'll criticize.
Thank you. When we think about how to design this, we thought that if we set up the default setting as opt-out, it's actually encourage people to stay in the database. So we separate the two scenarios. When we talk about the academic research, we still stick with the opt-out because now we already released data for third party to access. So there's no much difference to just ask people to opt in again. That means reconsent, it will cost too much. But for the commercial use, because we think the public interest is probably not that high, or probably people will really be willing to express their consent or their willingness. So we just set up the default setting as opt-in. So people can decide whether they will be really happy for their data to be shared with commercial company or drug company for commercial use. So that's why the two scenarios will be different a little bit. But I think based on the result, we can still try to figure out what's the best scenario and mechanism we can satisfy and the most people's feelings in Taiwan about how do they choose whether to opt in or opt out for their data to be used in the future. Thank you.
Can I have more comment? Actually, around 2 years ago, we tried to use some data from, the people, deceased people. They already died, yeah. But their data is also very useful for, we call for some high biotechnology or some commercial use, yeah. But the group from the human rights, they're strongly against. We don't get the permission from these people. But they're already in the heaven, yeah. So how can we get the permission from them, yeah? But we think it's a challenge for us, so we just stop such kind of program, yeah. I think for us, yeah, if we can do more, it's really good for Taiwan people. This is why today my talk is talking about the big data of Taiwan, NHI. This is quite different from our country. We are also respect the human rights, but we should negotiate with the Taiwan people, yeah. In that way, if we can, have some commitment, I think it's good for Taiwan Island to be better than before, yeah. So, any question or comment?
Dr. Lee, we might have to maybe take one last question. We're about to wrap up the session.
Yeah.
Yes.
Okay. If no, we have to say thank you to all our audience here and the online audience. Yeah. Thank you very much. Yeah. Thank you.
Thank you once again to our moderator, Dr. Lee, and also our two speakers on the stage. Please come to the middle. We are going to have a photo together. 那接下来呢，我们请这个主持人、署长以及2位讲者到中间来，我们一起合照。那我们今天呢，也有好几位这个健保署的组长到现场来，我们是不是也到台上来一起合影啊 ？And we also have quite a few division directors of National Health Insurance Administration joining us this afternoon. We would also like to invite them to the stage to have a photo together. 我们有请吴淑慧组长、张宇斌组长、戴学勇组长、江淑静组长、李纯富组长、张温温组长以及李明玉组长。组长有请。Let's have a photo together on the stage, and thank you very much to our moderator and also panel speakers for giving us such a wonderful discussion. Thank you. 都可以啊。署长，你还要再找哪几位贵宾上台都可以。署长，您直接帮我们唱名一下好了。现场有哪几位贵宾应该上台来合照的？
来，不要客气，我们健保难得今天来这边健保好不好？健保同仁请上来一下。
好，我们上台来一起合照好不好？
一起难得哈。佩珊可以上来，那个知宇上来吧。那个一姐，
好，我们台上的贵宾在合照，那其他的贵宾以及我们线上的朋友们，接下来呢是我们休息的时间呢，我们休息到3点10分，休息到3点10分，等一下3点10分回来呢，还有这个主讲场次3。Ladies and gentlemen, we take a break right now, and when we come back, it's plenary session 3. It will start at 3:10. We'll see you later. Thank you.
OK。不要站2排啊，站1排就好。
我怕后面的贵宾被挡住了，对，可能最两边的贵宾我们是站出来一点点，站成一个圆弧状，这样可能大家都可以入镜。好，署长再帮我们问一次。好。好，再次掌声，谢谢，谢谢署长，谢谢台上的贵宾。那接下来是我们中场休息的时间，我们休息到3点10分。3点10分，请贵宾呢准时回到会场。We have a break right now. We'll be back by 3:10. Thank you. Ladies and gentlemen, welcome back. And very soon we have come to the last plenary session of 2021 Global Health and Welfare Forum in Taiwan. We're going to have a look at the impact and consequences of the pandemic on sustainable development. 很快的，我们已经来到本年度最后一场的主讲场次哦。我们要探讨的是疫情对于永续发展所造成的这个影响。And ladies and gentlemen, now please join me in welcoming your moderator for this session, Professor Huizhen Jenny Su, President of National Cheng Kung University, Taiwan. 让我们掌声欢迎场次主持人，国立成功大学苏慧珍校长，掌声欢迎。
Thank you. Good afternoon from Taipei, Taiwan, and to those of you who are joining us from other parts of the world, good day. Welcome to the last session of the 2021 Taiwan Global Health and Welfare Forum, as we will be visiting a timely and most pertinent topic in terms of future global health, entitled Impacts and Consequences of Pandemic to Sustainable Development, where 3 informative and visionary talks will be given by 3 prominent scholars. As a key message sent by the recent Lancet report stating that the COVID-19 pandemic has demonstrated the need for increased international cooperation in the face of global crisis. COVID-19 recovery presents an unprecedented opportunity to invest in the future of economic and environmental sustainability, improve health, and reduce inequities. However, this would only be possible if the world acts together to ensure that no person is left behind. Decision makers must act today and show strong leadership. A better future then would be possible. Also, digitalization and regional cooperation are considered 2 areas of particular promise that can help create the foundation for resilient, inclusive, and sustainable development pathway. And this is also a very, very recent joint report from the advisory board of the UNDP program and hosted by the United Nations of Economic and Social Commission, specifically for Asian and Pacific region. So with that, please join me in welcoming the first speaker of the session, Professor Jason Wang, currently Director of the Center for Policy, Outcomes, and Prevention at the Stanford University. It's very much well known to us, particularly through his publication in JAMA last year, illustrating the response to COVID-19 in Taiwan, which has been viewed now for more than 1 million times online. Jason, I believe you are ready. Thank you. The time and floor is yours.
Yes, Professor Wang, you may start.
Jason?
Thank you very much for the very kind introduction, President Su. The topic of my talk is the future of digital surveillance and connected care, lessons from the COVID-19 pandemic. First, the financial disclosure. I am a co-founder of a medical technology company. What we have learned in the last year and a half by reviewing the practices of 20 democracies in handling COVID, we have generated 10 important lessons, key lessons on how countries respond. And I wanted to sort of summarize this by this one slide. So being a commander of a pandemic response is like being a conductor. So the conductor should know the music. However, this is such a brand new virus to us that many conductors had to improvise, if you will. Basically, they have to adapt to the situation. However, I think a commander needs to have logic, needs to be able to review evidence and change practice as new evidence are brought to the table. And then there's a sequence of events that needs to happen, and the conductor needs to know how to prioritize what should be done first, what should be done second, and so forth. And then there's the tempo. So you can't play the music in the same tempo. Sometimes you need to go fast, and sometimes you need to go slower. And finally, you need to be able to articulate what you're doing to the public, especially in a democracy. So articulation is very important to communicate the message. Now, in an orchestra, the first violins should practice together. The second violins should also practice. So they each need to know their part, and they need to ideally practice together. In this pandemic, we've seen a lot of pickup games, like a basketball pickup game, where people just go to the park and invite others to play with them. And so this won't go as well in a pandemic. So some of the major obstacles to avoid in a pandemic is what we have experienced today. First, there's a lot of technology and interoperability issues. A lot of issues with information transfer and data transfer. And also, because of the vast amount of data, that timely analysis and decision-making are very difficult. The laws are very confusing, and sometimes it's the jurisdictions. Who is in charge of what and who's allowed to do what, that's confusing. In the United States, we've seen federal laws and state laws, and also jurisdictions, they conflict with each other, and sometimes they're not coordinated. The use of technology for contact tracing is particularly an issue when laws are involved, what's allowed under the law. And finally, managing capacity issues. I believe most countries have had this issue, not only in terms of hospital capacity and availability of personnel, but also PPEs and testing. I just want to make sure people could hear me. Can people hear me?
Yes, we can hear you.
Okay, great. So we have had looked into 20 different democracies and come up with the 10 lessons. The first is command and coordination. And so having a good commander is very important. And the commander needs to be knowledgeable about the topic and need to be able to work with other people. So early on, many countries have politicians as commanders, which ended up being a mistake. And so I think it's very important to have a health expert in charge. The second lesson is border closures and mandatory quarantine and contact tracing. So this virus originated in China, and then it spread to other countries. So if the viruses are being imported to your country, I think early on, countries that had closed their borders earlier tend to do better. Now, if the virus already spread inside a country and is already in community spread, it's very difficult to know where the person got it from, and it's very difficult to do contact tracing. And we have seen this in the United States, which closed borders a lot later. And then Taiwan, for example, which closed borders immediately. Resource allocation is very important. The ability to make PPEs and to distribute equitably to the population. Let me emphasize the word equitably. You can't just distribute PPEs to rich people. You have to distribute them equitably to the population. That's very important. The ability to ramp up testing is also very important. So we have seen sort of these two issues being handled very well, for example, in Taiwan and also in Korea. In Korea, testing, they have drive-through testing. I think that's quite a good invention. And both countries limit the exports of PPEs, and they made more for the population, and in many cases donated to other countries. Now, in terms of mitigation strategy is, for example, in the United States, we have stay-at-home orders, so you can't go out. We close businesses here. And when you do that, it's going to affect people's lives. And so there's a balance between saving lives and saving livelihoods. That a lot of people won't have sufficient amount of savings. And so a lot of subsidies, government gives subsidies to allow people to stay at home when the pandemic is at the peak. The fifth lesson is handling vulnerable and special populations. So this is particularly important, for example, in the elderly. We've seen a lot of people die in nursing homes. Germany has done particularly well. They prioritize testing in nursing homes early, and then also quarantines for people who are infected in nursing homes. Migrant workers is another population that people need to pay attention to. So for example, in Singapore, we've seen a lot of migrant workers get infected because initially the government prioritized only the Singaporean population and not the migrant workers. And as a result, many migrant workers are infected, and then they went and then infect the Singaporean population. Managing uncertainty and variance in the reopening is also very important. We have seen, for example, in the UK, they started to do sequencing on the variants very early. In fact, about 10% of the infections have been sequenced. And then once they find a new variant, they could then study it to see if it's more infectious than the previous variant. And, you know, India, in comparison, when the Delta virus first started, India did not have the capacity to study variants. And then you know, it's very difficult to understand the impact until it started to spread all over the population. Developing, securing, and distributing vaccines is also very important. And so the United States, we have the Operation Warp Speed, which allowed the US to develop multiple vaccines that are very effective. And then Israel, for example, had been able to distribute vaccines very early by securing the vaccines, and also the distribution system was very effective. They were able to distribute to over half the population in a matter of 5 weeks, which is very effective. And then combating vaccine hesitancy and vaccine apathy is the next battle once you have the vaccine. And then there tend to be a plateau after a while, and how to convince different subgroups in the population on the safety of the vaccine and also why they should get it. People need to spend a lot of time being hyper-localized about the solutions and not just have one sort of message, but multiple messages to different populations. Handling surges and variants has continued to be a problem. And then many countries are now developing strategies to now quickly react or act when they see a variant. And you know, vaccines only does a certain amount of work, but in the future, there's going to be oral medications where it's going to be a game changer, and people, after they're infected, could then take the oral medications and feel be at less risk for being hospitalized. Adjusting to the new normal is going to take a while with the sporadic outbreaks, even with the vaccines, and then really test the psychology of the command. When do you relax? When do you tighten things? It's almost like a heart. In a heart, when the heart is pumping, you need to both squeeze, which is, you know, when you constrain people, and then you need to relax. It's the diastole. You cannot squeeze all the time. If you squeeze all the time, the blood wouldn't pump. So it's very similar to COVID. And so this slide I just wanted to illustrate that in the COVID response, you know, all the way from screening, diagnosis, and management, is actually a very complicated series of events that needs to happen from symptoms and signs of detecting COVID. We now know that a lot of the cases are asymptomatic. So it's very difficult to use symptoms to screen for people with COVID. During sample collection, for example, the reliability of collecting a good sample, even before the analytics, is only about 75% at the most. And so sometimes you need to do it multiple times. Even the tests, PCR tests are more accurate than rapid antigen tests. But then there's the cost issue and also the timeliness issue that needs to be addressed. In contact tracing, you have to triage people, you have to have enough contact tracers, and then you have to figure out who needs to get hospitalized when they test positive and who could stay at home. So it's also a major challenge to a lot of countries. In immune testing, because the build of immunity, both natural and vaccine-based immunity, we are still trying to understand how to study immunity in COVID, and so that's a continual process. Therapeutically, we started with IV medications, and now finally there's opportunities maybe later this year to have an oral medication. But we have to think about the cost of administration. If you're doing IV, you need the personnel, you need facilities to deliver IV if that's what you have. In terms of vaccine development, we have seen not only the need for vaccine, but also cold chain requirements and distribution channels, and people actually to deliver the vaccines. When people recover from COVID, sometimes they have long COVID or post-acute sequelae of COVID that we need to continue to address. The contact tracing piece, I wanted to particularly focus for this talk, because it's quite complicated. For example, in the United States, where I live, Santa Clara County, when the provider orders a test, it goes to a laboratory, usually not actually in the provider's office, and then 10% gets faxed to a county health department, and 90% gets uploaded to a state web portal. But the county people have to manually download these to their county contact tracing team. And so by the time they do all that and they try to trace down the possible exposed, sometimes it's 5 days. And so a lot of people would have been spreading the virus already. Now, if you use the digital method, for example, using the Google, Apple exposure notification app, you have more of a chance to reach more people more quickly. And however, in the United States, and I'm sure in many places in the world, this is not so simple. So suppose somebody gets infected, and through the exposure notification app, which is Bluetooth based, is like you're trying to hook up to your earphone. The Bluetooth technology very similar, except it's low energy. It has a handshake. If two people are close enough with their phones for 15 minutes, they will do a handshake. Then you could send it to a server, which could then notify anybody who has had handshakes with this person in the last 14 days. However, if the person then, let's say I live in San Francisco area, travel through Chicago to go to Boston, then I've been in 3 places, but where's the server? The server is in California. So even if I were to notify people with the handshakes, only the California people will get it, and people in Chicago and Boston wouldn't necessarily get the handshakes from the Bluetooth notifications, the Google, Apple exposure notification. So we're talking about, in this era of digital contact tracing, the need to go across jurisdictions, the need for different facts and statistics to be compiled from the process of managing COVID, from screening, diagnosis to the management. We're talking about data systems that need to talk to each other, the data interoperability, the various data sources that's needed, the numerous points of entries and access of data, and the data coordination piece. Ideally, the data should center on the patient, but currently the data is centered on healthcare institutions. And healthcare institutions and public health institutions They are separate data systems in the United States. The medical records do not talk to the public health records. And I'm sure that's also true in many countries. So in the future, we have to figure out how to have the data talk to each other. Now, Taiwan has done something really ingenious in the beginning of the pandemic, which is linking the National Health Insurance database and the Customs and Immigration database by sending batches of people's travel records in batches to the National Health Insurance database. So when a patient is seen, that they know they had just been traveling abroad. And so this allowed the doctors and nurses to be alerted when somebody had just returned from abroad in the last 14 days. So when we talk about digital epidemiology in the future, whether you use the Google, Apple exposure notification or other methods, we're really talking about case detection, contact tracing, isolation, and quarantine. And this requires trust of the public and participation. So you're going to have new data sources from your cell phones, maybe wearables, maybe video surveillance cameras, social media, and QR codes that people need to do the QR code before they enter a supermarket or I heard that is happening in Taiwan. Internet searches and news crowdsource for symptoms and self-reports. We need to think about ethics. And the ethics needs to be weighed on the ethics of using the data versus the ethics of not using the data. So sometimes when the disease is very deadly, it spreads really quickly, it's ethically justifiable, but ethically, it's not just justifiable, but ethically obligatory. So what is it? How do we handle this? And I think there's the question of informed consent and choice here. So for the Google Apple exposure notification, it can reach a lot more people, and people usually don't remember who they will be in contact with, particularly in the metro, and it allows data gathering very quickly. However, it needs to have a widespread adoption to be effective. It could lead to false alarm and false reporting. The data integration and regulatory issues are a problem. England and Wales have successfully implemented this Google Apple exposure notification in their country. And they have shown that the more people using it, the more cases are averted. And also for every 1% of people using it, the cases decrease by approximately 1% as well. And this is with about 50% of the people adapting to this app, and also 70% of people revealing that they have COVID when they actually have it. And so what we're looking to is, this is an Israeli report where China is the most centralized surveillance using facial recognitions and social scoring. Israel is also very centralized. It actually uses the Secret Service, and it has caused a lot of backlash. Taiwan and Korea are also centralized, mandatory. Initially, it was GPS-based, then it switched to cellular, and then QR code-based. France, Australia, and New Zealand, they are voluntary. They're centralized model. They've mostly used the Bluetooth exposure notification, the Bluetooth low energy, or QR code-based, and Italy very similarly. When we look at the Freedom House, sort of the freedom score, we look at different countries. For example, China is 10, is like not free, and Israel is 76, is more free. And there are usually legislations backing this kind of the use of technology. Okay, and this is the list of technology. These are the references that you could look if you want to know more. Taiwan has a freedom score of 93. We have the Communicable Disease Control Act in Taiwan, and now it mostly uses cellular signals. And so as we move forward, we need to think about privacy issues, the cell phone location and text data. GPS is a little bit more invasive than cellular signals. GPS tracks your exact location. Cellular signals approximate your location. We need to think about autonomy, asking for permission to access personal records and informed consent. We need to think about equity concerns, who's getting their data gathered and for what use. and we need to minimize the risk of error. Sometimes you do it incorrectly, the data is not correct, and the speed and the source. And finally, we need to do accountability, that there needs to be a transparency oversight for the data. You need to have an oversight so that the data is not misused. We still want to go with, this is the final slide, we still need to go by a few principles. First is by reference to the counterfactual, what would be used instead of the technology, and is that more or less desirable to the public? What will be the least burdensome or least restrictive in terms of available health resources, people's behavior without public health orders, transmissibility of the pathogen, and so forth. And then when you use algorithms to predict something, for example, in China, they use Alipay to identify people where their locations are, and they use a health passport. It needs to be accurate. And then if you're using algorithm to predict which region might be more at high risk, that's one thing, and that's most people are de-identified. But if you identify individuals, that's very invasive. Use electronic monitoring to support confined persons. We need to think about, again, the privacy issues and the desirability. In the US, it's very problematic. You cannot use electronic monitoring to enforce restrictions on movement. Supreme Court has held that judicial warrant must be obtained. So it's very difficult in the United States. Now, for use the cell phone data for contact tracing, like the Bluetooth exposure notification, you could make it mandatory or opt out or opt in. And so there are different methods to consider. And the process of obtaining stakeholder input and oversight will engender public trust, particularly in a democracy. So that's my talk. I hope I didn't go over too much. Thank you very much.
No, it's a perfect time control, Jason, so it goes just fine. I was just wondering, because I was told that Jason could not join the discussion session later, right? So he would leave us with a session, or do we take any question for the moment? Sure. Jason, do you have still a few minutes?
Yes, I have a few minutes. Yeah,
okay.
Sorry I can't join you. It's like 1 o'clock in the morning here. So I do need to go to work tomorrow. Yes.
Any urgent rising concerns here from the audience on the side? Or anyone from the virtual platform? Anyone online?
对，各位贵宾要不要把握一下机会？王教授，他等一下就要先离线了。大家有问题的话，请赶快把握机会。Any questions for Professor Wang?
Otherwise, I will assume that we usually have a very, very active communication with you at all times. So we would leave it as the discussion point next time when we meet again, either through virtual platform or when you visit back here in Taiwan. Thank you. And, another applause for Professor Jason Wang for joining us here. Great, all the best. So we will now move to the second speaker. And we probably all know that whenever a discussion for sustainable future is entertained, it often encompasses the people, environment, and the society. So the methodological framework to address these interlocking concerns in recent years is particularly based on a conceptual core of planetary health. So with that, we'll be welcoming Ms. Cunningham, who is a planetary health researcher from Griffith University Center of Environmental and Population Health, Australia. And she will be speaking to us on the topic of sustainable societies, rethinking climate change adaptation. Please welcome Connie.
Many thanks, Professor.
Yeah, you got it.
For your warm introduction. Are we good with the slides and audio?
Yes, I think it's loaded well. Now you can move.
Thank you so much.
Right.
Good day to everyone, and I'm very honored and thankful to share this important platform and also these timely discussions together with all these dedicated experts and practitioners, and of course the gurus in this field. Thank you all for just wanted to also take this opportunity to extend my appreciations to all of you for all you have done to being our role models that I look up to and inspirations for me to pursue in the field of public health and also planetary health. I would like to begin by acknowledging the traditional custodians of the land on which this presentation brought to you and pay my respects to their elders, past and present and emerging. And we are very grateful for their wise wisdoms and on guiding us on how we need to restore care to our land and protect our Mother Earth. As we meet today, actually, two back-to-back important conference. One is in Rome G20 Summit. As you can see this group photo, we are very happy, actually glad to see some of the doctors and emergency medical workers join the leader as we recognize their contribution to COVID-19 response. But sadly, and thousands of healthcare workers have sacrificed in the past 18-19 months in order for us to raise and keep health agenda high on the economic and political agenda. So thanks for all their sacrifice and contributions. And the second international meeting will be the COP, UNFCCC Climate Change Conference. And I hope we have good reasons to be optimistic that our leaders will pave their way from Rome to Glasgow to attend the United Nations Climate Change Conference, showing up with more ambitious goals. But we know that several important leaders will not be attending in person. And we also know many of them are showing up empty-handed. So it will, has been discussed that it might also be a disappointment for us this year that we are having no concrete or bold commitment from our leaders. As we can see from the evolution of time, we have already been working so hard in this field. Thanks for everyone that are contributing, giving us in our generations this beautiful earth, and we are hoping that we can also pass on this beautiful earth to our next generations. But we will see, and we have still hope, but it's the window, opportunity of the window is closing, and it's coming very, very small right now. So this is going to have a lot of consequences, and I have seen the program of this 2 days conference. There's this dedicated and exclusive session talking about climate change and children health. And this is not very common in the past. I guess a lot of the health conference and environmental conference, the climate change doesn't get into the health agenda. But I think since 2015, the Paris Agreement, health agenda and health sector's voices are becoming more louder. Because the health consequences are real. It's not very distant. It's happening in front of our eyes. And all of the evidence and science are suggesting and looking at such complex impacts on people's health. And the impacts of climate change and health includes, just very briefly mentioned, direct impacts, such as the heat and extreme events, indirect impacts through ecosystem, which includes impacts on global food supplies, changes in vector-borne diseases, transmission, climate-sensitive diseases, and also some of the indirect impacts through socioeconomic systems that are exacerbated by increased poverty and intensify of existing inequalities and migrations. While we know that there's no one safe from this risk, climate risk, but the people whose health is being harmed first and worse by the climate crisis are the people who are contributing the least to its cost. And we can see this skew, very weird looking map. It's actually the size of the climate-related mortality by country, 2000 to 2030. This is a projection that we can see. So the people who are in low income or disadvantaged countries and communities are disproportionately impacted seriously and severely by the climate change. So with the current commitments, putting the world actually on track to 2.4 degree of warming through the modeling. So if it's 2.4, we are expecting to see all of these impacts on the slides. There are, I'm sorry that I don't have much good news to brought to these impacts or the climate change risks that we are facing. And climate action failure actually being ranked as the first and the highest global risk in the next 10 years. And elevating health in the climate debate is our top priority in the next decade. It is because actually the rapid decarbonizations could prevent most of the 3.3 million deaths from air pollutions that are occurring each year and 842,000 deaths associated with excessive red meat consumption and result in better physical and mental health from high exposure to nature and more physical health. So as far that all these slides are showing, the science is clear, and I believe everyone would agree that tackling climate change is the greatest opportunity for global health. And never before in our lifetime, on 6th of September 2021, over 220 leading medical health journals worldwide have issued a joint call for world leaders to take emergency actions to transform societies and limit climate change to restore biodiversity and protect health. So we know that climate is changing, but why aren't we? Is it too busy, or are we just focused on the day-to-day job that are so occupying us? Or our training or our atmosphere or our environment just have us to have time to react to demands. When problems arise, crises arise, we do better than doing more prevention or proactive activities. Or we are already in health, in public health, we have already done a lot for health already. So we have a moral offsets that climate change or environmental change or planetary health is something that are far away from health, that are very distant or in the future. Or actually we are in a system that reward more for activities, more testing, more vaccination, more treatment than what is the alternative activities or approach that we can actually solve the health crisis together with the environmental crisis. So, or perhaps all of the above. And a question that I really think about is what are we really saving patients through our treatment or our approach or interventions, or are we generating more patients? So in this 2 days conference, I heard a lot of the speakers touching on points like healthcare ecological footprint and how are we so wasteful in some of the interventions and procedures, and how can we more be effective and to develop towards sustainable. So a lot of the information and ideas all around the world may be inspiring, but to become solutions, they must be put into actions. So how can we take all these ideas or information from published papers, get them off print, then realize in the real world? So literally, the colleagues at the WHO cycled the talk. They cycled from Geneva to Glasgow in the last few days for 800 kilometers to deliver the health voice, the health argument for climate change, joining together a long way with a lot of healthcare professionals that are demanding leaders to rise above politics and fight climate change together. So in this health argument, we have 10 of them. So one among them is clearly pointed out that we need to build health resilience to climate risk. Then what is health adaptation or building a climate resilience, environmentally sustainable health system means to us? So in IPCC 2014 report, it pointed out that what is adaptation means it's a process of adjustment to actual or expected climate and its effect. And in human system, adaptation seeks to moderate, to avoid harm, or exploit beneficial opportunities. So I'll be summarize some of the principles that are guiding us to what is effective resilience and climate change adaptations. So I will also illustrate some of the real world examples that are drawing from my own work and also my colleagues and my teams. And how do we actually apply those principles in a real project? So how these ideas can also lead us to expand our notions of what counts as climate adaptation towards planetary health or SN health interventions, creating also new opportunity for climate and health related activism. And I'm also see how we can also specifically open up more effective adaptations and collaborative research. So the first one, an evidence-based risk management approach. Okay, so for research to benefit society and populations, in our center and our group, we believe that it should be useful, usable, and used. So it means that we can translate complex knowledge into useful policy and practices, and complex sciences to usable tools, and also translate useful and usable knowledge into actions. Then we have research that are impacting our populations. So this is the first example that my colleagues did for dengue in Vietnam, dengue preparedness and control in high cluster in Mekong Delta region in Vietnam. So we knew that we have a lot of modeling and evidence to help us predict some of the climate sensitive diseases, including dengue. But this modeling can be useful, but is it user friendly? Some of the public health authorities or local community, can they understand and how they interpret these kind of results from the modeling? So we took another further steps to how do we make all these results into simple scorecard that are corresponding to plans and strategy. So it rank according to color, and we know that the red is the dangerous threshold that we need to take urgent actions. So in dengue preventions or modeling, we can go up to weeks that we can see there would or might be an outbreak that we should prevent, and also some of what are the key stakeholders and communities can take part in actually prevent this outbreak. So if this, when we see this scorecard, sometimes we might also be sitting in a document or a policy plan, and how can we put it in our fingertips and seeing when the weather's all the relevant information coming in, they can calculate and calibrate some very short and fast informations that help inform decision making. And when this comes in, we also have to have a system or a mechanism to help the decision maker. What are the policy options that we have? And when we take the first one or the second one, what are the consequences or expected results that we can have? So this is an evidence-based risk management approach that we bring from useful some of the informations. We ask ourselves, is it filling the research gap? Is it helpful to solve the problem identified? Is it improve the existing practice, and also answer the so what question? So the information has to have also the next steps. What will you do following when you get those informations? And turning down into, if we, as an effective early warning system, it should be usable. Is it ready to be used? Is it understandable, user-friendly, feasible to use? Who are the stakeholders who should be involved in this conversation? Will they agree? And also, if it's usable, then we can expect the next step to be more useful and usable. Co-develop and also co-produce with the stakeholders and actions. And finally, after, if it's being used, how do we also evaluate and feedback and see how we can improve the system or the process? So we are trying to create a win-win responses to. So we believe that what is good for addressing climate change and creating a sustainable world of including planetary health is also good for health and healthcare. So we need those positive messages on what we can do to protect our future. Need to emphasize all these win-win solutions and talk together about what the evidence is and what those messages can be. So the second one will be like, how do we factor in some of the climate risks into decision making? This is the work with the Health Promotion Administration with the Health Promoting Hospital Network. They have pledged in 2009 to reduce 13% of their emissions together collectively. So in the data, we show that what are the strategies or what kind of interventions can help hospitals to reduce their energy use. And what are the options they have. So when the resources arrive or the opportunities or the technology is ready, they can immediately and also embed it into their planning or also decision making. And the third principle is helping the vulnerable. So I think during the pandemic, we all learned that our healthcare workers are really vulnerable, and especially when we don't have enough PPE to protect them. And you can see in this picture is in the Philippines that there's small message up there saying that you have to remain in your PPEs because you don't have enough of them for them to change. So you can see those healthcare workers working under 40 degrees hot weather. They are exhausted and they have to work. And we don't know, we haven't seen the end yet. So how can we help these people? I think in the early days when PPE was very scarce, we partnered with the team in Taiwan hospitals that we learned about this, that WHO guideline saying that we have to rationalize use our PPE. And one of the strategy is using a physical barrier. So taking in this idea and also working with all the people, then how do we make interventions really implemented in the hospital setting? And because of the time constraint, I'll just go through some of the examples and how do we link some of the health intervention with also reducing our emissions and taking care of, and also feedback of the policy or guidelines in the international. And this is also another one in Nepal and some of the collaborations that we have in the region that we make use or also some of the local languages. And this is one of the principles that we're revisiting some of the decision and outcome over time. The red line is actually the flood line. So you can see in the second picture, the generator actually being moved up above the flood line, but the question and discussion was saying, is this good enough? How high should we go? So these are always we need to consult and also be very mindful with the decision makers and what are the current context and climate risks actually bring us. And the next principle will be collaborative and value-based approach. We work together with the Australian Medical Students Association, our next generation, the future leaders. They come up with the hackathon activities, and the groups gather between medical students and also other kinds of discipline students. And they have a lot of ideas on how do we improve sustainability in the hospitals. Although these are kind of small projects, but we sometimes say that sometimes those smaller steps get us further along. Also shared responsibility, and I'm also the Asia Pacific Women Leaders for Planetary Health focal point. We emphasize on gender and also equal who are not actually missing in this table. How do we be more inclusive when we talk about climate change or planetary health? This is also another some of the case studies that I will skip through that we also like working together with people that are vulnerable, but they can exchange some of their health services with plastic waste, plastic bottles. And in Brisbane, we and our team are actually putting up a proposal to call for the 2032 Brisbane Olympic to be the first zero plastic waste event. So we work closely with our medical supply industry to achieve this monumental goal. So besides those principles, I think climate change adaptation, I think for me as an early career researcher, and I'm also in a learning curve, I think it requires inclusive relationships and also a thoughtful strategy, and of course, effective communications, and last and most importantly, a transformational partnerships. So I will end this and hope to learn more from you and engage with your ideas and your work. Thank you very much for your time and attention.
Thank you very much, Connie, who have actually taken us through a journey where a different subgroup, and very, very meaningfully, whether it's from the youth group, the homemakers, or the nurses, who are all able to make their contribution as part of this exercise and the forces to really tackle the global issues of climate change and adaptation. And I think it's also a lesson that we all have the opportunity to come back and visit how the complex science can in some way to be translated and then being part of this community exercise. After all, it's actions. Action would be, at the end of the day, truly change our daily practices. So our last speaker for the session will be Professor Sir Michael Momon of the University College of London. Professor Momon served as the president of the British Medical Association in 2010 to 2011, and as the president of the World Medical Association in 2015. He was knighted by Her Majesty the Queen for service to epidemiology and understanding of health equities. He now directs the Institute of Health Equity at UCL and will be the best person to deliver thoughts on building back after the tremendous pandemic of COVID-19. Sir, the floor is yours.
Thank you. And it's a great pleasure to be with you. It would be an even bigger pleasure to be with you in person, but that will have to wait for another time. I will explain why I've called this Build Back Fairer. It's fairly obvious, I think, but we produced two reports that I want to talk about with that title. The first thing to say is the opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. Particularly during a pandemic, we think a great deal about the health care system, but my concern here is with the conditions that make people sick. And I must say, we are not doing well in the United Kingdom. This is COVID-19 cases per million people. There's the UK. The United States looks pretty good compared to the UK at the moment in new cases. We had a politician on the BBC recently saying countries like Taiwan, which did very well in the first part of the pandemic, are not looking so good now. And I thought, what is he talking about? Here's Taiwan down here. What is he talking about? And there's the United Kingdom and the United States. And countries like South Korea, Japan, Hong Kong, Taiwan have done brilliantly well throughout the pandemic. There's been some ups and downs. And we see this, we hear very much in a country like the UK, in the United States, in Europe, it's a choice between controlling the pandemic on the one hand, but saving the economy on the other. And that's a false choice. GDP growth from the previous year and 2020, reduction in growth in all countries, but the lower the death rate from COVID-19, the less the reduction in GDP growth. There's Taiwan, and there's the United Kingdom, Peru. The US was somewhat protected. It took economic steps, but in general, the better the pandemic was controlled, the less the negative impact on the economy. And again, in the UK, our politicians are saying it's a race between the virus and the vaccination. Well, vaccination is, of course, very important. UK has higher vaccination rates than Taiwan, but we've got much greater burden of COVID-19. It can't just be vaccination versus the virus. It's got to be other things. And these are data from England. If you classify people by where they live and classify where they live by the level of deprivation, the dark green is all-cause mortality. And you can see this remarkable social gradient. The greater the deprivation, the higher the mortality. And here's COVID-19. It shows almost identical gradient with all causes. It means the causes of inequalities in COVID-19 are very similar to the causes of inequalities in health more generally. So yes, we do have to control the virus, but we also need to deal with the underlying inequalities in society. That tackling inequalities in health is a way of tackling inequalities in COVID-19. And that then leads me to Build Back Fairer. Two reports that I want to talk about: Achieving Health Equity in the Eastern Mediterranean region of WHO. I chaired this commission and we reported in March 2021. And the COVID-19 Marmot Review in England, we reported in December 2020. So let's come back to the Eastern Mediterranean. The so-called Eastern Mediterranean is remarkable in it stretches from the western end of the Mediterranean, Morocco, much of North Africa, the Middle East, Djibouti and Somalia, and then Iraq, Iran, Afghanistan, Pakistan. So geographically, it's a lot broader than the Eastern Mediterranean. And we took the line of do something, do more, do better. This was the conceptual framework. We have structural drivers that we need to deal with, conflict and its consequences, economic and commercial determinants of health, culture and society, and of course the natural environment and the climate crisis. Conditions of daily life, we had recommendations about each of these: maternal and child health, early years, education, employment, healthy aging, built environment, and health systems. And our general approach: do something, do more, do better. What do I mean by do something, do more, do better? Well, in the region, these are countries looking at access to basic services. In Sudan, fewer than 40% of the population have access to basic sanitary services. Afghanistan, it's probably deteriorated since these figures. Yemen, fewer than 60%. Do something. Provide clean sanitation to people at risk. Whereas in Kuwait, United Arab Emirates, the occupied Palestinian territory, the vast majority of people have access to sanitary services. Do more. This is the percent of women who agree that a husband is justified in hitting his wife. This is women agreeing that a husband is justified in hitting his wife. Afghanistan, more than 60, 70, 80%. It depends crucially on education. In Morocco, women with no education, nearly 80%, say a husband's justified in hitting his wife. But with higher education, it's 20%. In Jordan, it's under 10%. Dealing with domestic violence has to be, when I say do more, has to be a priority. And we need to do something, sanitation, and more at the same time. We shouldn't be waiting till people have clean water before dealing with the issue of domestic violence. Do better. This is tax lost to corporate tax abuse annually. Corporate tax abuse. In Egypt, $2.1 billion annually lost to corporate tax abuse. Pakistan, $2.5 billion. Saudi Arabia, $2.25 billion. UAR, $1 billion lost annually to corporate tax abuse. Do something, do more, do better. I won't go into all the recommendations we had in each of the specific areas. In the UK, as I said, we published our Build Back Fair report in December 2020. We said, as we emerge from the pandemic, we should not want to go back to the status quo ante of where we were before the pandemic. In fact, before the pandemic, in February 2020, we published Health Equity in England, the Marmot Review 10 years on. So I've got to go back further now. I chaired the WHO Commission on Social Determinants of Health. We published our report in 2008. And the then British Prime Minister, Gordon Brown, asked me, could we apply the findings and recommendations of your global commission to one country, England? So I conducted the so-called Marmot Review, Fair Society, Healthy Lives, and we published in 2010. We said, here's the evidence. This is what you need to do to reduce health inequalities. So on the 10-year anniversary of my review, we look back. How well had we done over the last decade? And my simple summary is we lost a decade, and it shows. This is pre-pandemic. Life expectancy had been increasing about 1 year every 4 years in women and men. That's going back to 1980. I could take it back to 1890, and life expectancy was improving about 1 year every 4 years. And then in 2010, the rate of increase slowed dramatically and just about ground to a halt. What happened in 2010? We had a new government elected, a conservative-led coalition government. The government said, surely you can't be suggesting it's anything we did that could have led to this slowdown. Well, we need to look at the question and see what the data show. They said, maybe we've just reached peak life expectancy. It's got to slow sometime. So we looked at other countries. Life expectancy improvement in weeks. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czechia, Spain, France, Switzerland, Sweden, Germany, UK. My goodness. We had the most marked slowdown, the smallest increase in life expectancy of any rich country except Iceland and the United States. No, we had not reached peak life expectancy. Other countries were improving faster than we were. We're doing something wrong. Secondly, we observed, I've shown you the social gradient in health. We observed the fact that the social gradient got steeper, the inequalities got bigger, and life expectancy for the poorest people went down. They got sicker. Those in the most deprived 10%, shorter life expectancy. In 2010, I had 6 domains of recommendations, the Marmot Review called Fair Society, Healthy Lives, to reduce health inequalities. First, give every child the best start in life. Education and lifelong learning. Fair employment and good work for all. Number 4, everybody in a rich country should have at least the minimum level of income necessary for a healthy life. healthy and sustainable places and communities, and taking a social determinants approach to prevention, not just telling people you should behave better, but dealing with the social determinants of behaviors. So what happened? The government in 2010 had as its mission austerity and rolling back of the state. And they did it. In 2010, public sector expenditure was 42% of gross domestic product. And over the decade, that went down and down and down. So by the end of the decade, the 42% had become 35%. They really did roll back the state, reduce public expenditure. In my 2010 review, I introduced the rather awkward term, proportionate universalism. Here's the social gradient in life expectancy, let's say, or some other health outcome. Social distribution, it's a gradient. If you focus only on the poorest, you miss the gradient, the fact that we should want to level up. We should want everybody to have better health below the top, those below the top to have better health. So we want universalist policies, but effort proportionate to need. The National Health Service is an example of proportionate universalism. It's available to everybody. It's a universal service, but effort proportionate to need. But we could also define need, not just medical need, but on the basis of the social distribution, deprivation, for example. So what did we get in England post-2010? The grey bars are total spending by local government, local authorities, and divided by a degree of deprivation. So in the least deprived 20% of areas, spending per person from 2010 went down by 16%. The greater the deprivation, the greater the reduction. In the most deprived areas, spending per person by local government went down by 32%. This is effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could this have contributed to the slowdown in improvement in health and to the increased inequalities? Yeah, I think it could. I won't go through all of the recommendations, but let's start with early childhood. Child poverty. Child poverty is defined as living in a household at less than 60% of median income. In 2010-11, 18% of children in England were in poverty before housing costs. After taking housing costs into account, 27% of children were in poverty. And over the decade, that 27% went up to 30%. Child poverty increased. There were a lot of other negative things that happened. But that's where we were before the pandemic. And then we had the pandemic. And as I've already shown you this inequalities in COVID-19 were very similar to the inequalities in all causes. The pandemic, as predicted, exposed the underlying inequalities in society and amplified them. And the steps taken to control the pandemic, lockdown, increased inequalities. Richer people could work from home. Poorer people either lost their jobs or had to go out to work in frontline occupations where they contracted the disease, or lived in overcrowded, possibly multi-generational households. I think of health as a measure of societal success. And you notice I call this Build Back Fairer. And pre-pandemic in England, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of rich countries. And during the pandemic, we had, certainly in the first half, the highest excess mortality. So excess mortality is because of international differences in the way cause of death is applied with COVID-19. It's asking how many deaths would you have predicted to have occurred in 2020 based on the previous 5 years? How many did occur? And that's the excess. And what we see globally is, in general, the worse the health improvement pre-pandemic, the bigger the excess mortality during the pandemic. And I asked myself, what's the link? And I was thinking about the UK. And I think poor governance and political culture, increasing social and economic inequalities, reduction in spending on public services. We were ill-prepared coming into the pandemic, and we were unhealthy. So in my Build Back Fairer report, thinking of health as a measure of societal success, I had specific recommendations linked to those in my 2010 review. To remind you, give every child the best start in life, early child development, education and lifelong learning, fair employment and good work for all, healthy standard of living for all. Everyone should have at least the minimum income necessary for a healthy life, healthy and sustainable places and communities, and taking a social determinist approach to prevention. But we also need to deal with these poor governance and political culture. We need to reverse the social and economic inequalities that had been increasing. We need to reverse the reduction in spending on public services and deal with the fact that we were unhealthy. And so building back fairer, I argue, means putting a fair distribution of health and well-being at the heart of all government policy.
Would that be all?
Thank you.
Thank you. Thank you. Thank you so much, sir, for showing us and with the concrete and most direct evidence from your analytics. And personally, I'm most inspired by your genuine concern, where the most deprived are usually the subgroup that receives least attention and expenditure-wise, specific measure-wise. But I think your report definitely demonstrates your concern, and we certainly will follow to do something, do more, and do better. I realize that we are just a few minutes over time, but I think the opportunity is very precious. And through the web box, there's already one question coming for the two panelists that are still remaining online with us. And the question is the following. Given the need for doing better in pandemic response, in climate change adaptation, and in overall health systems governance, what are three immediate and top priorities we should be doing collectively and be accountable? Are leaders becoming less effective and less competent around the world? If you don't mind, Sir Maman, would you be willing to go first?
Sure.
Thank you.
Sure. So my approach to this is to be general and specific. The general, I said when I finished my talk, put equity of health and well-being at the heart of all government policy. But I would add that has to be sustainable health equity. So sustainability has to be at the heart of all government policy, and equity of health and well-being has to be at the heart of all government policy. And as Connie said earlier, they go together. They shouldn't be separate approaches. They go together. And we need to do them at the same time. And then there's a wealth of specific evidence-based actions that we want governments to take. The Glasgow COP26 began yesterday, not very far from where I'm sitting. The Prime Minister of the UK said it's 1 minute to midnight. It's 1 minute to midnight. We've got 1 minute to save the planet. But it's got to be done in a way that is equitable between countries and within countries. So those two priorities have to be done in tandem. So save the planet, sustainability, deal with the climate crisis, and equity of health and well-being.
Let's try to do all we can for that 1 minute before midnight. Connie, your comments as well?
Thank you. This is really a good, important question, and it's not really easy to answer because there's so many priorities that we need to do yesterday. It should be done actually yesterday. If it's for me, for the top 3 priorities or actions that I will suggest, I think first is a good one, is start the conversations. You ask the questions. We are not forcing or rushing to the answer, but taking a time to pause, practicing the pause, and really look at the bigger picture like Sir was presenting, what are actually in the helicopter view, what can be done, and find the leverage and opportunity to have more synergized collective actions. And second, I guess we'll also look at around of you. These people are your allies, right? So form a team, look at the circle of influence. How do we join the network to make our voice louder, make it a collective a movement to make this more sustainable? And the third one is just our leaders becoming less effective. If you're not happy with it, just be a leader by yourself. Be the change that you want to see. Be the leader that you want to see. So I think that's the 3 things. Thank you.
Thank you. Thank you for your feedback. Any other immediate inquiries from our audience here on site or online? Maybe before we end, I could have a very, very quick one going directly to either Sir Maman or Connie. Earlier in Professor Jason Wang's comment, he emphasized quite extensively on the functions or the future prospect of digitalization transformation for all countries around the world. Would you agree or would you comment that those countries who now have the better information communication technology infrastructure will now be better positioned in the future to build back fairer society after the pandemic, or there's other way or other perspective to really look at this holistic system? Connie, you want to go first? And we will leave Sir Maman to end the session. How is that?
Sure, thank you. And looking forward for your views, Sir. I guess I'm not the digitalized or digital expertise, but I will always go with balance. So how do we find balance? Nothing over will be a good thing. But of course, the accessibility and how the poor and the disadvantaged, marginalized populations can be equitable, have this access will be my first questions and priority. And how do we allocate our resources, prioritize our resources? Who are making this decision? Are we revisiting our decision? What kind of indicators or data are informing our decisions? So these are the things that I would think about when we talk about, I think, every aspects of our interventions. Thank you.
Sir?
So digitization, we can see that we, to use the expression, we have a tiger by the tail. you pick up your newspaper every day and you read something more about Facebook and how it controls the planet. It's got out of control. It can influence elections. It can damage children. It can do all kinds of things. So this set of technologies that is undoubtedly a force for good can be a force for bad as well, that it can be out of control. And if you look at the biggest corporations in the world, they're all the big tech companies. So they're making fortunes out of you and me. And we have to ask the question, how is that improving the equity of health and well-being of society? So I'm not anti-technology. It's a force for good, but it's got to be harnessed. It's not, right, now we've got digital technology, we're going to solve the world's problems. We may create a lot of problems. So it's a force for good, and it doesn't replace dealing with the conditions in which people are born, grown, live, work, and age, the social determinants of health. So we need to harness this tool for good, but we also need to be dealing with the quality of early child development and preschool, the quality of education, the nature of working conditions, and so on through the life course that are vital to health and well-being. So yeah, we've got to find a way to work with this technology. And as in Alice in Wonderland, Humpty Dumpty said, the question is, who's to be master? And is the digital technology going to master us, or are we going to master it?
Great, thank you, Connie and Sir Mammon. With, I think, the enthusiastic stories told by Connie and the wise wisdom shared by Professor Mammon with all his career, we can all remain hopeful that we will definitely work together to leave no one behind. Specifically, I believe what we could do is with a more sufficiently strategic and bold investment in key drivers of the development, and the global community can then move beyond a crisis, therefore into an opportunity. With that, I thank you for both staying with us through the session, and we look forward to seeing you both physically here in Taiwan. Until then, stay healthy. Thank you for joining the session.
A big round of applause to our speakers from Australia and the UK, Connie and Sir Professor Marmot. And of course, thank you so much to Professor Su for her very skillful and also very smooth moderating. Thank you so much. Ladies and gentlemen, 2021, the Global Health and Welfare Forum in Taiwan is coming to an end. Lastly, to share with us some of his concluding thoughts, please join me in welcoming Dr. Chongliang Shi, Vice Minister, Ministry of Health and Welfare, Taiwan, to the stage to give us the closing remark. Let's welcome Dr. Shi. 接下来呢，我们论坛的最后，让我们一起掌声欢迎主办单位卫生福利部石崇良次长上台致闭幕词，掌声有请。
Distinguished guests, ladies and gentlemen, good afternoon.
Good afternoon.
On behalf of the Ministry of Health and Welfare, I would like to thank our guests, speakers, colleagues, and all the participants of the Global Health and Welfare Forum in Taiwan. Thank you for your support, participation, and most importantly, for exploring and sharing how society can remain sustainable and healthy during the challenges brought about by the pandemic. I would also like to extend my sincerest gratitude to the Ministry of the Foreign Affairs and the various departments and administrations in the Ministry of Health for their tremendous support, undeterred by the ongoing stress of the pandemic. The forum not only retains its rich keynote content in a physical format, but also include the invaluable inputs by experts from Europe, United States, Australia, and Japan in an online format. Your exchange and insights on how to keep the social welfare and the health policy remains uninterrupted during the pandemic, and how to promote inclusiveness and the resilience of our society through diverse strategies will contribute to ensuring the sustainable growth and the health and the welfare of our future generation. As my colleagues told me, it is estimated that more than 1,000 participants, both physical and online, from public sector, private sector, academic experts, and the medical professionals, as well as the local and international students, have attended the forum. There are over 1,000 online participants from 43 countries. So we are extremely moved and grateful by the enthusiastic support and participation. So finally, I wish everyone the best of the health, and we look forward to seeing you again in the near future in Taiwan. Thank you so much. Thank you.
Thank you very much to Vice Minister Shi. 非常谢谢次长。Ladies and gentlemen, 2021 Global Health and Welfare Forum in Taiwan has come to an end. We would like to firstly thank all of our speakers for their insights and valuable inputs. Let's give all of them another big round of applause. 我们试试再次热烈掌声，谢谢我们2天论坛所有讲师精彩的分享哦。Most importantly, we thank you very much for your participation, staying with us till the last session. Thank you so much. 我们当然呢也非常谢谢所有的这个贵宾呢踊跃的参与哦。Thank you once again, and we'll see you next year at 2022 Global Health and Welfare Forum in Taiwan. 谢谢大家，我们明年再见，谢谢。那我们提醒各位贵宾离场之前呢，请记得要归还口译设备哦，随身物品也不要忘记了。再次谢谢大家，也祝福大家呢有个美好的一天。Please do not forget to return your headsets and earphones. Don't forget to bring your personal belongings with you back home. Thank you once again. Have a great evening. Thank you.